Good afternoon to everybody. I'm very happy to receive you and to say hello to you. Thank you very much for coming on a Saturday, which is very, very much appreciated. But we wanted to make it together with the Day of Rare Diseases, which we are celebrating today. So we thought it would be a good idea and basically concentrated on our young patients, which is something which is not being discussed very much. I know MPN Voice has also, activities for young people, but I think the problems of the young patients are completely different than when we have people in my age. So I thank very much that we have first Professor Haifa Al-Ali from the I have also to look it up from a sorry from the University of Halle in Germany. Sorry, Haifa. It's always a problem for me. Then we have Natalia, which is also a hematologist in St. Thomas NHS Foundation Trust in London, and then our good friend Marta Soba, a hematologist from Wrocław, from a medical university in Wrocław. Sorry, Wrocław. Thank you very much, all three, for coming. What I would like to ask now is to make a very short representation of our patients, which are here for a moment. I just would like that you give us your name, where you're living, what kind of illness you have, and when you have been diagnosed. And then afterwards, we go straight to the questions and we start discussions. And maybe Oscar, you are far away. Why don't you start? Just be, your name, when not diagnosed, and where you're living.
Hi everyone, my name is Oscar. I live in New York City. I was diagnosed in 2022 December, and I am an ET patient with CALR mutation.
Thank you very much. Aroa, welcome. Didn't see you for a long time. Aroa, can you hear me?
Aroa.
Bueno, Aroa, can you
Hola,
hear
buenas
me?
tardes.
Hola,
No hay
buenas
problema en que
tardes.
hable en español, ¿no? No.
No, bueno,
Vale,
Yeah. Haifa,
muy
you
bien.
can switch
Pues yo soy
into the
Aroa y soy madre de Irati, que es una niña que ahora tiene 11 años y cuando tenía 8 tuvo una trombosis portal, una trombosis en las venas del hígado y así descubrimos que tiene Polycythemia Vera y la mutación YAC2. Y bueno, ya está en tratamiento con interferón y ahora mismo pues se encuentra muy bien haciendo vida de niña de 11 años y contenta y bien, ya llevamos un camino recorrido que, bueno, pues estamos mucho mejor que al principio, que hace
muchas
3 años. Sí.
Haifa, you can have translation. Inge, can you explain?
Yeah, Haifa, if you choose down the round bottom that calls interpretation, you can switch in from English to Spanish and from Spanish to English in case any one of you need.
Yeah. Okay, Sasha, up to you.
Hi, I'm Sasha. I live in Barcelona, Spain. I'm 34 and I was diagnosed with primary myelofibrosis when I was 17. And I'm currently on momelotinib as of 2 weeks ago.
Great, congratulations. Anja?
Can you hear me?
Yes.
So I'm Anja. I'm from Frankfurt, Germany, and I was actually diagnosed at birth, me and my brother, with hereditary thrombocytosis. And I've started taking aspirin since a month, and it's really helped me already. And yeah.
Good, thank you. Emily?
I'm Emily. I'm from Louisville, Kentucky. I was diagnosed with essential thrombocythemia just this past November, and currently on the Hydrea chemo, which has actually just recently got me into normal platelet levels this past week. So I'm very excited about that.
Very good. Mylene, you just disappeared. I wanted to give you your short story.
Yes, I'm Mylene
Mylene, sorry.
from the Netherlands. I'm 29 years old and I was diagnosed in 2022 with ET.
Thank you very much. Good. So we had basically two free fixed questions which we wanted to discuss. I will just start with the first one, which is worrying me since a very long time. We are used, that MPN is an illness for older people, so it's starting let's say 55, 60, and so far basically the physician he had to find a way to procure a good quality of life for a patient for the next 20 years. Now, here with the young people which we have here, this has totally changed. You have 20, 25 years old persons, and you have to find a treatment for the next 60 years. So it's totally reversed. I think this must be a hard thing to settle for the physicians. And we have three of the top people here today. I would very much like if you could tell me, how are you handling that situation? And maybe Haifa, please, maybe if you could start.
Me a question.
I know, it's a good question.
About AYA patients, yeah, this is always very, very, very special for us when we see such young people in front of us and when we make the diagnosis. And for me personally, this is a real challenge. As you said, completely different goals of treatment, different expectations. And so we have a completely individual approach. And I think we will discuss this in the time.
Yeah. Marta, what is your experience in this respect?
Similar to what just Haifa said. I mean, when I was studying hematology, I always learned that MPN is the disease of older people. But once I started to collect younger people diagnosed below 25 years of age, it appears that there is a lot of young people diagnosed of MPN, even as we just heard, very young children. So yeah, and when I started to speak with pediatricians that they are treating children, they are even with much more problems that we are, because it's really difficult to diagnose and to treat these children. So this is why we work on this topic, and we have to change the perspective, how to diagnose, how to treat, how to manage, how to speak with these people. And my main problem is that I've got just only 10 minutes per patient. And once I've got the young patient, this 10 minutes, it's not enough.
Yeah. But I think that's a general problem, which
Yeah.
I think in your countries we have in Spain exactly the same thing.
Yeah.
But and this is not very much we can change. It's a part of the system. But and I think this is why we do need to have this kind of meetings in order we can explore a little bit more, what really can be done. Natalia, have anything to else? How are you handling that in London?
Yeah, well, I'm echo everything that has been said to start with. We always thought when I was in medical school, MPN was for old people. Well, let's define old people. That's number one. And number two, I guess we are slightly lucky, and I will drop the first thing there because we have this what we call TYA service in the UK, which is a teenagers young adult service. So it's kind of a logistic approach. So you have a special nurse, you have a dietitian, you have a psychology, you have a consultant, and they support in a different way, because it's, for me, I'm not going to have the same conversations someone is on the 80s that someone is on the 20s. It's really, really different, right? For so many, even if they have similar questions, someone on the 80s is not going to be worried about having family or what's going to happen in 20 years. Which obviously is a big question when you confront a young adult, or not even talking about teenagers. When we have a few cases, and it's really challenging to manage, because there is probably questions that we can't answer right now. And I think Marta is doing a lot of work on that. In the long term, what is the impact, what we can do to make this better. In a positive side, I will say that we probably have better treatment options now for young patients, that we know it will work. And then is this hope that obviously, we're doing a lot of research, and that will be impact positively going forward on the patients. And we know better about the disease. So I think that is a really positive side for us to show to our patients. The timing to see a patient is the challenge as well. We give 10 minutes, we kind of spend an hour, and then you have another patient waiting for 3. But it is what it is. You have to give that time. But I will, I mean, this is the only big difference probably with me, is we have this TYA service, which is quite nice in a way, and it's really helpful for our patients. Yeah.
Thank you very much, Natalia. What I mean, for long-term treatment, what do you consider today? And you can talk. It doesn't have to talk only you. If Haifa or Marta, if you have an idea, you can just follow it. What are the treatments today which you would consider for a long-term treatment?
I think, well, sorry, I'll take that. But I think my first option in a young patient would be PEG interferon. That would be my first option. For some of them, they need treatment. Obviously, if you don't need treatment, then
sure. Wait and see.
Yeah.
Yes,
maybe. Sorry. No, you.
Yes, I think wait and see is okay, but I think I personally always say wait for what? So I have a very low threshold for treating, because I don't know why we should wait in most of the cases until we have problems. So as soon, quality of life is not that much in the guidelines for treatment. It is mainly the risk of thrombosis. But for young patients, it is really quality of life, symptoms, which really matters very much. So I personally have a very, very low threshold for starting interferon, in the hope not only to improve the symptoms, but also to try to delay, modify the natural course of the disease. And I think at present, we are living in a very, very exciting time with new chances, particularly for the patients now at present with calreticulin mutation. We have this very nice studies going on with the antibody against the mutated calreticulin. The first very, very specific treatment. It's beautiful. And indeed, I do have now a little group of very young patients, actually with myelofibrosis, calreticulin, who are now receiving the antibody. And we hope that this is the beginning of this very precision, detailed, individual treatment.
This is what we supposed to do. I mean, we should treat this patient before what Haifa just said. I mean, before we've got any problems, thrombotic complication, progression of the disease. So now we've got interferon. In Poland, we are really lucky because we've got also ROPEC interferon for PV patient. So this is what we have to do. Of course, we have to follow up side effects of interferon, but this is what we should start as the first line. and not waiting too long, yeah, because it's not only the symptoms control, but also the prevention of any side effects. And in young people, it's really difficult to know when the thrombotic event occur because we don't have really good risk scores. So this is a problem of young people.
Yeah, but are there studies going on for that in that respect or not? For the risk thrombo.
But we need, I mean, we are speaking about these studies, but we need new risk factors that we still don't know which one would be. So
I see. I understand. Okay.
And
Good.
if I can add something, Peter, I think as we probably have changed, I mean, Marta and Prof can mention, but I think we have changed our mind. Before we were waiting, as Prof said, to see something is going to happen. Now we are more, okay, let's just, like, even a low-risk patient, this is something is going on for the last few years, a low-risk patient PV, it may not that low risk as we think. So it's better, let's treat and prevent a problem than actually treat the problem when the problem is there. So I think that's what our mind as a, doctors in MPN has changed a little bit to be actually, let's start treatment. And I totally agree. We sometimes start treatment just because of symptoms or quality of life that is affected by those symptoms. So, you don't have to wait until the platelets are 2 million. You can start when they are lower than that and prevent the problem. So
yeah. So it means basically that the wait and watch fear is not so much accepted anymore. You prefer to start treatment at the earlier stage, yeah? Is that right?
Right, but there are still a few patients doing very well with watch and wait. If they don't have symptoms and nothing, and the platelet count is stable, then this is still acceptable. But the threshold for starting treatment for us is now going down. As I said, symptoms or whatever, a gradual continuous increase in the platelet count, we don't wait that long until a complication happens.
Okay. Thank you. Milene, why don't you explain a little bit more about your MPN history? What happened, how did you get diagnosed, and how you're living today with your symptoms and side effects?
Yes, I can. I had like a kyst near one of my ovaries, and they got it away with surgery. And then my platelets were still very high, like 600, around that number. And then my internist internist doctor, she found it very strange, so she started some more investigation of my blood, and then she found out the CALR mutation, and that was in 2021. And since then, I actually got blood thinners like Ascal, and I've been using them ever since. But I haven't been on any other medication so far. But the numbers are like slowly increasing. So right now I'm somewhere around 1,000, 1,100.
1,100,000, I assume, no?
Excuse me?
It's about 1 million, no? You said
Yes.
yeah.
I only see it in hundreds or
Oh, I see.
1,000. That's the
Okay,
only
yeah.
number I see.
Yeah. Okay. And how often do you go to the physician?
I go once every 3 months for a blood examination, and then my doctor also asked me if I have any details that I want to share, how I'm feeling, stuff like that. So it's also a lot about quality of life.
But your quality of life at this moment is okay, yeah?
My
Quality of life.
Well, I'm really curious about all the other people in the group because I have, for the first couple of years, I didn't have any symptoms at all. And I just knew that I had this disease, but I didn't feel like being sick or having any symptoms. But actually, since January 2025, I discovered that the symptoms were increasing, and that I actually started to feel more fatigue and less concentration, stuff like that. And right now I am working for 75%. So I made a deal with my work since, I just couldn't handle working for 100% anymore. And I have a really nice two bosses, so they are okay with it. But yeah, we made like this deal that right now it's working out for me. But yeah, I'm very curious how the rest of the group is experiencing this.
Okay. From the physician side, what do you say to that case? Any comments?
Yeah, this is okay. This is I would have done the same, first watch and wait. As I said, but we know today that the young people, many young patients have the calreticulin mutation, that many patients have an ET. We know that the disease in the young patient is a completely different story from the old patients. We know that the prognosis, that the clinical course is much better in the young than the old. And I think more and more we are learning that it is something different. And that's why we are now, learning, all of us are learning, to look at younger patients differently. And, she seems to have a great doctor, because I think everything is right, and one has to decide when to start. As I said, I will repeat myself, as Milene herself said, she is calreticulin, she has 1 million platelets. We will have in the next months even the clinical studies for patients not having thrombosis, but if the platelets go above 1.5 million, then there is the option to be in the trials treated with the calreticulin antibody, because I personally believe in this antibody. It's beautiful. And I think this might, in the very next few years, will make a complete difference. The same is true for JAK inhibitors. We are now in the era of having more and more and more and better JAK inhibitors for JAK mutated patients. Again, we have so many studies now starting. So I think, and I hope that in the next 5 years or something like that, we will have really treatments, not just for symptoms, not for hope, but really making a difference. And maybe this is too early, even go for, I'm very careful with this word, cure. But this seems possible now.
Maybe
Marta,
maybe this is also the difference between patients with JAK2 mutation and CARL mutation. So CARL2 mutation, it's usually better, less thrombotic. So this is why in your case, I think that we can still watch and wait. I do agree that it's a really good solution for you. But in case that you would have much more symptoms, then we can think about changing the treatment. But as Haifa said, it's the best solution to get to the clinical trial with CAL antibodies. It would be the best solution for you. Yeah.
Any questions, Milene?
I think not. It's for also, as my doctor said, it's very hard to like decide the line where to start or where to watch and wait, because it also depends not only on numbers but of course on quality of life. And he also explained to me that the any type of medication that you take, that it's like strong stuff. So he prefers not to start with it when it's not very necessary. And I don't know if starting treatment will actually help me with my symptoms, or if it's only going to make me feel worse or more nauseous or more fatigue.
Okay. Good. Anja, can we have your story a little bit more in
Yes.
details?
So maybe my story is a little bit different because officially I don't have an MPN, I think. So because hereditary thrombocytosis doesn't even have a classification, it doesn't have guidelines. So my story began when I was born. Like I said, my brother and we were born with hereditary thrombocytosis, and we were diagnosed when we were like 2 years old, I think. And we regularly went to a hematologist like every couple of months when we were children, just to do a blood check, but we never did a bone marrow biopsy or anything like that. So they just checked our bloods regularly, and they also said to watch and wait. I think my brother, when he was like a baby, he even got aspirin, because when we were like really young, I think my platelets were at 4 million. His were like at 3 million, I think. But then later on, when we grew older, my platelets were at like 1.3 million, and his started to go down a lot more, but mine didn't go down. So we just, for the next years, when we were children, we went regularly, but they never told us that, they only told us that there was a risk for thrombosis, but nothing else. So when I was like 15, I couldn't go anymore because it was a children's, I don't know how to say, children's,
Doctor, yeah.
doctor. So when I was 15, I didn't go anymore because I didn't saw the point. For me, it was not that dangerous because they didn't make the risks clear to me. So the years passed. I'm 27 years old now. And like the last 2 years, I started having symptoms, headaches, dizziness, visual disturbances. And no one ever told me that hereditary thrombocytosis could have symptoms. So I thought it was like, maybe I didn't drink enough, didn't sleep enough. So I brushed it off. And then I started doing research. And the only thing I found was essential thrombocythemia. And like a couple of months ago only, I found out that people with essential thrombocythemia have the same symptoms as me. And for me, that was a shock because no one ever told me that. And then I also found out that people with my disease can acquire or get myelofibrosis or acute leukemia. And like I said, no one ever told me that. So the last 2 months, I started going to a hematologist again, and I explained my symptoms to him, and I had to ask him if I can regularly take aspirin because I heard that it would improve the symptoms. So I decided that I wanted to do that, and I've been taking aspirin for like a month now, and my symptoms improved for like 90%. They're almost gone, and I find it crazy because no one ever told me that. And I also did a bone marrow biopsy 2 weeks ago, and I got the results a few days ago, and it showed that my megakaryocytes I had too many of them, but the core I think is healthy. And yeah, and they also did a lot of gene tests, and so far I think it's called triple negative, so they didn't find any genes, and they made even more tests, and there was nothing to be found. And from what I've read with hereditary thrombocythemia, it's like incredibly rare, so they only do like studies on like a few families in the world, and depending on what gene defect you have, you can have different symptoms or different risks, like leukemia or myelofibrosis. So I don't know what defect I have, so I don't know what's going to happen, but I'm kind of used to it. Yeah. And that's my story.
Interesting. Yeah. Well, I think that two questions coming up here is I always thought that our illness is not hereditary, so you cannot pass it on from mother to the kids. Apparently, there are cases which are existing, and what are the difference of these thrombocythemias, which she has been explaining. some of the doctors could start to give a
Yes,
reply.
maybe I can. We know that familial hereditary thrombocytosis is present. We even have hereditary polycythemias. Mostly the defect is not in the classical genes we know, calreticulin, not in the exons and in the region of the gene. But we know that about 10% of ETs, of the young people, they have this so-called polyclonal hematopoiesis, meaning that you can look and search as much as you like, and still you cannot find anything. That means we still don't know. We know, but also that some of these young people, if they are not polyclonal, they might have some mutations even in the JAK2 or in the MPL, but not the ones we know for the entire group. We call them non-canonical mutations. So my questions to Anya, was there a whole genome, a whole exome sequencing, or was it just the classical genes?
I think they just did the classical stuff because I got the results from a doctor like 3 days ago. They still have to send me the documents what they did. They didn't have even time to explain to me of which genes they were looking for. I told my hematologist to look for THPO and MPL because that's what's often causing hereditary thrombocytosis.
Yeah, but my advice is with the results, you should go to a genetic doctor because then you have the chance, this is your right, you and your brother, to know what is going on because it is a standard at human genetics to do a whole genome sequencing. So one can really see much more and understand what is happening.
Do you know if like it's covered by health insurance?
It is. It
Yeah?
is. This is for every young familial, every kind of familial disease. It is, and especially if they are young, this is a must. This is an absolute must-have to be seen by a human genetics because they have, as I said, a standard. It will be covered by the insurance as well in Germany to make this whole genome sequencing.
Okay. I didn't know that. Thank you.
And I think that before you go to these doctors, you should also check out in your family if you have much more cases, because maybe there was no information because nobody checked the morphology carefully, and it can appear that your grandparents or aunts or whatever, they've got the same problem. And then maybe it would be interesting to know if they've got any thrombotic events, because it could help also to know if you would have higher or lower risk of thrombotic events.
Yes, this is interesting because the human genetic people, they make the whole family tree for the whole generations. And that's why it is very nice to have all the information because they really make, and so one knows does it come from the father's side? Does it come from the mother's side? Maybe there are other people who are at risk and they still don't know. Yeah. So this is very important. So human genetic person is a must.
So if I can say one more thing, when we were born, my mom didn't have any high platelets, but 15 years after we were born, her platelets suddenly, for no reason, she didn't have an accident or anything, started to go up. And then after a year, they started to go down again. And she also did many tests and they didn't find anything. So I likely have it from my mother's side. And she also told me that her family, some people have high platelets also. So.
I mean, can you discuss between yourself, our three doctors, about this question of hereditary? You know, I'm a bit lost now. Do we have a possibility that it's being inherited from a mother to a kid, or is that only rare exceptions? Or how do you see that? Could you discuss this a little bit between the three of you, so that I would like to get more clarity on this point.
Okay, maybe I can start because I was studying the Spanish family when I was working in Spain. We had a huge family with at least 6 affected members, and there is no direct I mean, there is no that mother and child that would have the same disease. It was like 2 generations of difference between appearing the disease or not. The problem is that there were people with ET, PV, and myelofibrosis, so a different stage of the disease, and they've got different mutations. So it's not so easy to predict. It's really rare. So usually when I speak with young people and I diagnose them that they've got MPN, I try to explain them that they have low risk, very low risk to give the same disease to their children. But yes, it's possible, and it's really not easy to say how it's how it's hereditary or not, and the phenotype of the disease, it could be really different. So it could be ET, it could be PV in one family. And as I told, in this family, there was JAK2 mutation and CAR mutation. So it was even more difficult to diagnose this family.
If may I add something, because as we've been talking, there is a difference between the classical mutations, so the CALA, MPL, and JAK2, and then we have, on the recent years, discovered more mutations that are not in kind of the classical MPN setting, and we have a new whole classification recently presented in the UK for BSH guidelines about thrombosis. So we are even progressing more on that, and I think, I mean, and probably Marta and Prof agree with me. We are, with all the new next generation sequencing, all the genetics that we know, we are discovering new mutations on JAK in different areas, or in other mutations that may be related with thrombocytosis. So I think we have moved probably in the last, I would say, 10 years, like significantly on that. And we probably are, even the triple negative ones, I always say, well, maybe in 5-year times we have a new mutation, and then we go back and found these patients, right? Because if we're thinking about it, when we discovered color, it was in 2013. I mean, most of you were babies, even if they were born there, right? I mean, our daughter was not even born, if I'm not doing my maths incorrectly, right? So my point is we are still discovering things. So maybe in a few years we come and say to Anja, look, actually this is a mutation, and now we know it's related with MPN, and this is, and I think this is also really important that we are conscious that we are moving a lot on that. And even for us, with this new classification that we have in the UK, we're now having patients that we call thrombocytosis of a non-significant. So we know you have a high platelet, but we don't know what is the mean on that in the long term. So it's a learning for us as well. And it is really hard to explain sometimes to the patient. I'm sure Martin, Prof agree that something is going on, but you can't put it on the, okay, you have ET color, easy for us, right? And it's really exciting on the other hand, because we're learning more and more. So
yes, I think we have to make the difference between hereditary, because sometimes, we have these point mutations in families, and there are a lot of publications for isolated families, and I'm not sure if this hereditary, classical hereditary, is really an MPN.
Yeah.
And then what Marta said, families who have a JAK or calreticulin mutations. And so I think these are 2 different things. And I'm sure that Anja might have just true hereditary cases where there is a very small mutation in a very small area of the big JAK gene. And this can be found if you go to a human genetic doctor.
We do have a similar case, have sort of similar patient like you.
And maybe then we know that this is not an MPN, but something
And we have, as Prof mentioned, with the genetics team, that they did the next generation sequences, a JAK2 mutation in a different area, not the exon 12, not the exon 14. And they discovered through the father, which it had some, I think it was planning for a surgery or something, and they noticed a high platelet and they couldn't find anything. And then it was the daughter and their brother is where I'm waiting to see him in my clinic to do this analysis. And they have the same picture. I give aspirins is fine. So, but you have to go through that. Sorry, Marta.
No. It's really interesting.
I mean, saying that obviously this is really interesting cases for us, and we all are try to collect in all of that information and put it all together, like not only in one country. We try to do our international collaboration because not that many people.
Not that many people, and this is what difficult diagnosis of very young children with MPN or hereditary thrombocytosis or hereditary polycythemia, because usually when we check 3 driver mutation in very young children, they do not appear. So this is a problem. Do they exist, or it's not so sensitive tests because it's so low allele burden, and I mean the amount of the mutation, yeah? Or do we have mutations in different sites? So this is a problem of diagnosis of very young children, especially till age of 10 or 15. Then it's usually changed like in adults, but in very young children, it's really, really problematic.
I mean, most Haifa, you have no children, for example. No, you only have adults.
Yes, we treat, but we work very close with our pediatrician, the children's doctors. We have a common clinic called CAYA Clinic, Children and Young, children, adolescents, and young adults.
Yeah.
And we work together. You know, when they get 18 per law in Germany, you are moved to the adult doctor. This is crazy for all cancer. And then we are making this together. So we have a transitional outpatient clinic where we see these patients together and, you know, for 3 years until they are above 21. So they get used to our 10-minute stuff. And, you know, we are different than the pediatrician who are really much nicer than
Yeah, but this is what I'm jealous about UK and Germany, as you told, because in Poland we don't have it. And then when we've got this 18 years old or 17 years old adult patient, it's really difficult to treat them because we are not used to do it. Yeah.
No, I'm not used to talk with that.
Yeah.
I have one, but no, but I have a couple of patients are really young, like 15 and 16, 17, so.
Isn't it so that most of the children they start normally with ET? I mean, very young of ET, and when they grow with the years, it's getting the symptoms, and it's improving. Let's say we're getting 12 or 14 years old, then slowly, sure, it's improving. I mean, I followed the case of Aroa, who's from Spain, and I've also some other families I've followed, and when the kid was 3 years, 4 years, 5 years old, you didn't know exactly what to do, but mostly they had very heavy headaches, and so they gave him small quantity of hydroxyurea or whatever, and then more we were growing, somehow this has been improving, has been stabilized. They were not cured, but they had a much more stable situation. Is that about a general situation of kids, or do I have a wrong impression here? Marta.
I'm not treating children, but similar like Professor Al-Ali said, I try to collaborate with pediatricians, and what they said is children usually has much more headaches. This is the main syndrome of children, MPN patients, and we know that at this age and in younger adults, there are much more cases of ET than PV. And there are much more female affected. So this is also problematic for the future because of problems of pregnancies that we are going to speak later on. So it's different disease. I don't know what to say more, but it's not the same disease of young children and young adults than for older patients.
Natalia?
Yeah, no, I agree with Marta. I mean, we have a good collaboration with our pediatrician team. So they, we try to do in the same day clinic and with them. But we don't have that many. But the ones we have are more ET young girls, and most of the time it's just the headache and the fatigue. But it's really difficult to assess in a teenager if they're tired. You don't know if it's hormones at school, whatever. But I'm always trying to ask them, actually, because I'm also joined what Milena said about the work situation. So I always try to double check they're doing okay on a school, because I think it's important, because obviously it could affect them, if they miss a school for headaches and going to the clinics and things like that. So you have to also keep an eye on that. But yeah, it's really, I think they are totally different. I mean, there's different. They're different, isn't it? I mean, Matt and Prof, we're not pediatricians, but you can see even when you have someone under 20, it's not going to be the same as someone older than that. So no.
Well, we actually wanted to have Dr. Nicole Kucine here today, but she's on a happy event. She's on a mother leave, so this is why she couldn't come. And but we normally have her in every year when we make these events. She's with us, and she normally can give us all the advice about kids. But anyway, thank you very much. I would like to give the word to Sasha, which is a little bit more complicated case, I would say. She has a different life or different story. But Sasha, please go ahead and explain your MPN story.
Yeah. So I started having symptoms since I was 15. Like I started getting very tired and like I couldn't go up a flight of stairs. It was extremely tiring for me, nosebleeds and a lot of things. But I kept going to doctors and they kept telling me, well, it's because you're young. It's because I remember one doctor told me it's because you just moved to Spain, because we moved here around that time, and just a lot of things. And then finally, a doctor did a blood test, and they were over 1,500,000. And this doctor, she sent me aspirin. And after a while of taking aspirin, I just started having hemorrhages, like really bad ones. And that's when they saw that I had the acquired von Willebrand syndrome. And so then they put me on interferon A for a while. But the side effects were very, very difficult. I couldn't manage it at all. And then they moved me over to Hydrea, and I became resistant to Hydrea after a few years. Platelets would not go down. They were just going up. I've had several thrombotic events. So when I had my first one in the portal vein, and while being on blood thinners, I had a second one in the portal vein, and now recently in December, I had another one in the lower part of the liver. I forgot what it's called. It's the VMS, I believe, or something like that. It's in the lower part. And then that caused a pancreatitis. They put me on interferon Pegasus for a while, but because I have a rare autoinflammatory disease, that was doing really bad things to me, like giving me a lot of flare-ups. And so I had to be taken off of that. And then what else? I've tried Chagrit. That didn't work either. Now recently I'm on momelotinib to try to kind of control the symptoms and the progression of the disease, because it seems to not be under control at the moment. It has been that way for a few years. I've had more complications like aside from the pancreatitis, pericarditis, I have esophageal veins, I believe it's called. And in my stomach as well, I have a few. And then the bottom of my stomach, it has like fibrosis, but it's not because of the myelofibrosis. It's because of the medication. It just caused chronic gastritis. I suffer from migraines, asthma, like since I was a kid. So I don't know if that has to do with the MPN. I don't know if that has to do with my other autoinflammatory disease. But well, like I get checkups and stuff with all of them. And I did have a not a great experience for 10 years with a hematologist. And that's when all the complications happened. But since October, I've been with a new hematologist, and she has really helped me understand more of the disease and more of like the complications and kind of understand everything, because I did for a long time kind of not want to think about it. I didn't want to accept that when I was 17, I had to kind of change my perspective of life and my goals, my plans. And people would tell me, well, you're young, you'll be okay. Like it's gonna be okay. It's just it'll go away. So nobody ever explained to me the illness as much as now this new hematologist. And now I'm kind of accepted like how to take care of myself, how to take care of my body, that I do have limitations because of like the complications throughout the years, that different things that I wanted in life. Like I might have to make decisions that are a bit different what I wanted, basically. And day to day, like it has affected me a lot. Like it's really hard to get out of bed sometimes. The bone pain, the fatigue, the brain fog is really bad. And my spleen, last time they checked, it was at 24. So hopefully with the new treatment, it will reduce the size, because that was giving me a lot of stomach problems too. And yeah, just taking it day by day. I see my doctor every week, my hematologist, and then my other specialists, I see them every month. So yeah, that's a little bit of my story.
Can you keep up a normal lifestyle, or is it, totally impossible that you keep a more or less normal life, or how do you arrange yourself?
Well, I tried to live like a full-on normal life. I had a 9 to 5 that was, I was doing overtime constantly. I had a lot of responsibilities at work. I would go to the gym, and I kind of like forgot about the illness. However, because I forgot about it, despite taking my medications and going to the doctors, that's when a lot of the complications happened, because I was asking of myself to live this life that I had dreamed of, when I have to kind of adapt myself, like not change my dreams, but just adapt them to what I can. So currently, for example, I haven't been able to work because of these complications. I've been in and out of the hospital for a while. And so then just taking it day by day. On the good days, like I try to do what I like, and I do try to keep like sort of a routine. So if I'm able to, for example, every day walk for 10 minutes, and I take those 10 minutes. If I can do more, I go for it. Do yoga, some type of physical activity, something mental as well. So then, you don't get stuck in your head. So I try to live a normal life as much as I can, and try not to see it as like I have to change my whole life because of this. It's just I have to adapt to it in a way.
Difficult, yeah. Haifa, do you have any word for this case?
Yes,
Probably
first
difficult
of
from
all,
far away,
this is really very, very strong lady. I really admire you. And I think it is so easy, to say things if you are not involved. But I think you said it very nicely. Take the day. It is only now that belongs to you. All of us, we don't know what will happen tomorrow or next year. I think this is really great, the attitude you are trying to go and cope with this disease. Very, very nice. I like it and admire this. And Peter said a very, very nice sentence. I am repeating this to many patients now in my clinic. He said, I try to make the disease a shadow. It is there, but I don't want it to affect my life. And this is what you are doing as far as possible. just one question to you. Do you have a JEC2 or a CALR mutation?
I have CALR. I actually, I did want to mention that throughout my trajectory of the illness, like being diagnosed till now, I've seen how it's progressed because when I was first diagnosed, I was JAK2 negative. And then when they discovered the CALR, I remember my doctor called me in, they did a test and they saw that I had it. So I have seen how it's progressed throughout the years.
Yeah, but for you, just I'm repeating myself, the trials with the calreticulin antibody, they are really made for people like you. So I hope the phase 3 trials will start soon. And I think if momelotinib, momelotinib could be very good, but the calreticulin antibodies might be a completely new chance for you.
Yeah, I'm looking forward.
You give the infusion, and after 2 days, the LDH goes normal, the platelets go normal, people feel so good. It is, I always say I've been very long in this work, but and I had only a few blockbusters, real big drugs coming. And this calreticulin antibody is really a huge blockbuster. It's so beautiful. And especially for someone like you and your age and all these complications, I think this will make a change. And maybe in the course of this year, the trials will start. I really hope so.
Yeah.
Thank
That would be
you.
great because that's actually something I forgot to mention. That one of my fears is that like I'm kind of staying without any options of medication because I can't be on Hydrea, I can't be on Pegasus. Shagrid is not good for me, and so momelotinib is my next one, and I haven't tried Ruxo yet, but that's because my hepatologist is very against it because of the liver issues I have. So these trials, like they are very like they give a lot of hope, basically.
Absolutely, absolutely.
Sasha, congratulations. You're really, when I look at you smiling, I would say it doesn't look like you are very, very sick. But yeah, this is what I try to explain to my patients too, that this is a chronic disease and you have to live with this and you have to take your day by day and you do it. And really, I admire you. Yeah, this is what I can say. And I just have one question. You told, because I've got a problem with connection, you told about autoimmune diseases. Do you have it?
Yeah, I have an autoinflammatory disease called TRAPS. It's from before it used to be part of the group of the familiar, no, it's like in Spanish is Fiebre Mediterránea Familiar, so FMF. So now it's like its own group, TRAPS, but there's like only 1,000 people in the world that have it. So it's extremely rare, and that's why sometimes I have to be careful with what medications to give me or what treatment plan to go for.
But
You're
this
an
is
expert of rare diseases, yeah?
yeah. But this is also the topic that we didn't mention before. Younger female patients, they can have much more autoimmune diseases associated with MPN, and MPN is inflammatory disease, and then you've got autoimmune disease that it's also inflammatory disease. So maybe your symptoms are so difficult because you've got both inflammatory disease that need to be, the inflammation need to be stopped. Yeah. And this is what we try to do with interferon that you can't use, but maybe with these new drugs that they are coming, we would be able to control both of them.
I'll just say I met Sasha a few months ago in person in Sene. So she's great. She's great there, but in person she's just lovely. But it's really, I think I write down as a word is adapt. And I think that is what is really important, to adapt the disease to your life. Your life needs to be adapted, but you also need to bring that in. And as you say, you take day by day. And, I echo my colleagues, these new treatments, I think, I have the same experience as Prof. The patients we see is a massive change. It's even I echo Prof. Harrison because he's like so excited. They say, and they've been working on this field for so long, trying to find something that actually it may make a difference for the future. So we are quite optimistic on that. And we're learning, but it may be, again, inflammation is something we are going through looking on. It's not only, again, but we open our mind and treating these conditions, right? We're not only thinking, oh, it's just a number, we need to put the platelets down, and we have to treat the whole picture. And that's where we are trying to develop more and more studies, combination therapies as well from other cases. It's kind of open our mind and see that it's just not a number anymore. Well, probably never been a number, but definitely not. But yeah, you're doing really well, Shasha. So it's always smiling, always.
Thank you.
Yeah, that's a rare special case. There is no question. Maybe it's a little bit more easier. Let's go to Marie. Well, most people probably knows you from different places. Why don't you give us a little bit your complete different story?
Hi, everyone. Just a disclaimer, because my Wi-Fi, I'm at an Airbnb and it was not working, so I had to run to McDonald's. And because of the rush, I didn't bring my earplugs. So just in case, if you don't hear me or something, just let me know so I can talk a little bit louder.
Okay.
So yeah.
Just don't talk too fast, yeah?
Okay, I will try. My Spanish rhythm comes with my English as well. So I'm Maricruz. Yeah, some of you might already know me. I'm 28 now, so it has been 4 years with PV. I got diagnosed when I was 24, and just by chance, I was doing a blood test. My platelets were more than 1 million or 2 million, something like that. I didn't have any symptoms, but it's true that I got migraines since I was younger. And now I'm honestly very shocked because whenever I talked about MPNs, everyone talks about migraine as well, and aura migraines specifically. So that's like a symptom that could be related to blood, not sure. But other than that, yeah, I have been living a normal life. And when I'm from Costa Rica originally. I was in Austria when I got diagnosed, and now I just moved to Madrid last year. So honestly, the biggest hustle has been more like in a bureaucratic kind of way, because I'm getting Besremi every 15 days since, I don't know, 3 years or something like that. And in Austria, that was super easy. I was working there, so the social insurance covered everything. But now that I moved to study abroad, since I'm not a European, I don't have like the social insurance coverage. So I still do the Besremi, but probably in the future, whenever I work here in Spain, I will change to Pegasus. So that's a little bit with the treatment. And I also like try to live like as normal as I can, because I mean at the end what's really normal. But I try to, as we already mentioned before, like to adapt a little bit my life to the illness, but not like, like I always repeat, it's a condition but not a condom. So I think like in the emotional part, it's always tricky, like to, I don't know, like to live one day at a time, and like not getting overwhelmed with like, oof, if I want to go back to Costa Rica, what can I do? And if I want to get pregnant, what does that mean? And if I, like before this, I was, I don't know, like very chilled about health in general. But now every time I feel something, I'm like, I'm getting a little bit more hypochondriac, a little bit. So in one hand, I try to balance it. In another one, I think it's also good that I have like a new perspective, that I take care of my health a little bit more. But yeah, I started the Odd Blood Club, that some of you might already know it, because I felt super lonely as a young patient. I felt like all the brochures, all the information out there was from like very old people that were living a different phase in life. And now we're like, I don't know, almost 90 young people in the WhatsApp group. And I think like the community emotionally, like all that support really changed the way I was living with the illness. So yes, other than that, I think, yeah, my life really changed with the support, like knowing stories like Sasha's, like Judith, like Oscar, like Simon's. I don't know, like the emotional part of having a rare illness. It's essential, and I'm very grateful for this type of like events and support because it really changes the way you live with it. And at the end of the day, my therapist was saying like the reality is that you will probably not die from the illness, but you can really die out of your mindset. So that really changed the way I was living with it. And yeah, already 4 years.
Good. Thank you very much.
Thank you.
Any comment from me, doctor side? Okay. I see here Simon. He is trying to get in the sunshine or the shadow. I don't know exactly what you're trying to do.
Yeah, no, I've just been booted out of the cafe, so I've just I've got to be I've been like shut out. I thought I'd just sit on the steps rather than jump in the car and drive home, just in case he canes me. So thank you, Peter, and thank you all for coming to me.
Yeah, please go ahead.
Sure, just a little bit about my story. So I was diagnosed at the age of 39. Didn't think I had any symptoms. I went in just to get a prostate check, just because I thought it was a good thing to do before I turned 40, and that came back with platelets at kind of 2.9 million, and a lot of uncertainty as to, hey, what's actually happening here, and a lot of confusion. They thought I had leukemia at first. We did a bone marrow biopsy. That came back about 2 to 3 months later, saying I had a primary myelofibrosis instead. So in terms of treatment, since that, it's been very much along the lines of what's being discussed. So trying to slow down the disease progression. So I've been on interferon since the start, kind of playing with different dosages, different kind of frequencies, and I've kind of found a balance at 180 mcg every 10 days. I've then thought I was all fine, kind of just get into a steady state, get back at work fully, kind of living life well. And then I had some thrombotic events. So I had 3 strokes about 15 months ago over Christmas period, probably the worst time to have a stroke and go into hospital and have the threat of having surgery. And then since that, I've been put on Hydrea, hydroxycarbamide. So I take that every day. And that's really actually, when they said I was going to start on the hydroxyurea, I thought that's it. Kind of, oh no, it's kind of a form of chemotherapy. You have all these negative connotations. And for me, being kind of early 40s, I thought, okay, there goes my vitality. There goes the rest of my hair. It's thinning anyway, but there goes the rest of it now, perhaps. But what's been remarkable, and something I want to share with others, is that actually that combination of the interferon, the hydroxyurea, and kind of clopidogrel to stop the clot risk again, has been transformative in that I've got the most energy I've had in years. I feel really good. I'm at the gym now, just being for a workout, and yeah, fully working, fully kind of feeling great again. And it makes me question how long I've had that kind of fatigue, and my platelets are still around the 600 mark, so they're still kind of elevated, but they're a lot lower than they were. And the energy I get from that is really helpful.
Great, Simon. Thank you very much.
Pleasure.
I assume no major comment from your side.
I would like to make a comment, Peter, if you don't mind.
Sure.
I have 2 questions. One, where in the UK are you? Because I can see that's not in London. That's to start with.
Yeah, no, I'm in Bath.
Oh, there you go. That's one.
There we are.
But the
There's the
other
countryside.
it is
Come down to Bath. It's great.
Yeah, maybe.
The RUH, please.
Sorry.
Obviously,
you can see the UK people will miss the weather, the nice weather. But the other thing I was just going to say, and I think is something that you mentioned, is about getting back to the gym, trying to do an exercise, and we have lots of discussions before with Ingrid and the team about how important is doing regular exercise and try to have a healthy possible life, which I think we are pushing a lot, unless for our MPN clinics, to try people to control, any cardiovascular risk factors. And I know all of you are quite young, but it's really important to start early to looking on that. And also there's a lot of studies talking about how to manage fatigue, how important regular exercise, good, healthy diet. I think Sasha mentioned yoga, any kind of mental support on that aspect is really important for the fatigue. And I think that is probably one of the most challenging symptoms I can confront with patients. I mean, it's just really difficult. I mean, I guess at Marta and they want to add in.
Completely agree. The one thing I'd say is that one thing that I do to kind of manage, and what I talked about in Barcelona, and I've just started up through it with Peter and Ingrid, is Qigong. So when I'm feeling kind of quite heavy, kind of feeling the side effects from the interferon, or maybe it's the side effects from the myelofibrosis, I really got into Qigong as a way of kind of cultivating that energy and unblocking things. And I love it. And I've just kind of qualified as a Qigong instructor, running courses and classes for the Wellness Project, and just really trying to get it out there. So anything that anybody can do to promote the benefits of Qigong, which is a lesser known kind of practice, which is very holistic, integrative, and grounding, would be massively appreciated.
Okay, if I can, once again, I really like to look at your picture because of the sun, because we're in the sun in Poland too. We've got the first day of sunny weather today, and winter was horrible. So yeah. This is one thought. And second one, I remember I've got a really crazy, but in a positive way, patient that was attending by my oldest colleagues many years ago as a young patient. And then he disappeared because, just only morphology controls and nothing else. So he said, okay, I'm not coming back. And after 15 years later, he came back, and it was my patient with 3 strokes, as you. Yeah, and I know that it was maybe a lifestyle, including as a risk factor, because he was smoking, he had some drugs problems also, so probably it helped. But I think that it was also the disease. And now, as you said, he's doing sports, he's not smoking anymore, and he's taking an interferon, and he's feeling really, really good. He starts his new life, and I would say the same, like Natalia. Sports are really, really important. Managing inflammation, managing the disease, but it's also antidepressive treatment. And this is what I observe when we put rehabilitation in all our clinic. I know that I'm running, so my resident doctors, they are saying that I'm crazy runner, so my patients need to run too. But yes, it works. I mean, doing sports, even during leukemia treatment, it helps really a lot, not only physically, but also fighting against depression. And this is what I think it's really, really important for all of you.
I completely agree. Oh, sorry.
No, go.
I was going to say there's a slide that I like to take a photo of in the Synopsis in Barcelona, which showed the link between doing sports and exercise and slowing disease progression, which my wife said I need to go to the gym more. But I completely agree with going and doing things.
I mean, if I can just put one example for one of my patients, he has thrombotic event as well. He's a young patient in the 30s. And he has a thrombotic event, splenic vein thrombosis. He's on PEG interferon. He does Ironman, which is just the next level of. And yeah, it's really, even with the PEG interferon, we try, obviously, if he's going to have a competition, because he's not going to that moment of like proper competition, you try to work around that. And I think it is really important. And actually, some hospitals are incorporating in patients that require chemotherapy for long term, so obviously not MPN patients, but patients with leukemia, they put in like bikes in the rooms to make the patients who have, obviously not the Peloton bikes, you just kind of have one that has the little pedals and then you just do something. And we are putting the physiotherapy, all the patients I see on the wards has been assessed by physiotherapy. So, you know, that's obviously extreme, but even in our department, again, lucky Guy's Hospital, we do this fatigue clinic with physiotherapy and occupational therapy teams. So they assess patients. And I have from young patients to elderly ladies on the 90s going to them and doing regular exercise, and they're absolutely fine. So, you know, it's not impossible. You just need to work around, and it makes a difference, even for the doctors as well. I'm with Marta. I'm one of those crazy persons. And it makes a difference when you have a long clinic and you go for your run and you get grumpy at the end of the day, you know? So it is helpful, and at the end of the day you need to take care of your heart and your mind. So yeah.
Haifa, you go for running also?
No, I walk a lot, but within the clinic. So
it's
I
the
don't
same.
run.
Walking or running, it's the same. Doing sports, doing any sport. Yeah.
Regular yoga is also really,
Yeah,
honestly,
exactly.
really
Yeah.
helpful when you have on calls and long days. So you see, everyone need it.
No,
join me with Qigong anytime. You're welcome. Everyone's welcome.
Yeah.
Some of
Can
you
I
know.
ask one more question, Peter? Sorry.
Yeah, sure.
Can I
Go
just ask
ahead.
one question? One thing I forgot to say is when I was first diagnosed, I was triple negative. I then had some further genetic testing done about 18 months, 2 years later, and it said I had CALR, which kind of chimes with what you've been saying about that being more prevalent in younger people. One thing I'm wondering about, hearing the amazing kind of clinical trials that are happening, is where can people like myself go to get that if we're in the UK or if we're in other countries? Like how do we get onto that if perhaps our hematologists aren't aware of it?
Oxford Guy's Hospital, I want to say somewhere up north. So we do have, Simon. We do have that in the UK. So it's a few places that have that open at the moment. Let's not go into the recruitment is getting challenged because of is a global study. So I can't remember how many in total are, but it's a big competition at the moment. But we do have.
It is actually now closed.
Is that closed for MF, isn't it, this week? Yeah.
Because you know everybody, but don't worry.
No, it will come
so fast. We had a call 2 days ago, and there is no place anymore because you know we are all competing for places. But you know the phase 3 clinical trials will start in the next few months, and usually more sites, different places will be. This was the phase 1 and expansion, the early trial with limited capacity, but the phase 3 trials, I think, will give more patients a bigger chance to be included.
And the I guess one good thing, and Prof, you were on, I wasn't on that call, but I know the outcome. I think it will probably go really quick because the results are really nice. So we're really optimistic about it.
Sounds very good. You know, some of you know we have a little tool which is called MPN Journal, which is helping the patient to keep more control about the symptoms. And in the month of November, we organized a challenge. We asked the patients who had been subscribing that they try to live for 1 month very healthy. You know, if you smoke, you stop smoking, etc. No alcohol, and you know, Mediterranean food, etc. Sleeping well, etc. And we got several results out of it. But what we got is that the symptoms were reduced by nearly 30%, which is amazing. So it's really, you know, if you really look at try to follow all what we are talking about, what we have been talking now about, exercise. Well, we haven't talked yet about food, but nutrition is extremely important. If you do that, you will be able to reduce your symptoms. I mean, the group which we tried out there, it was only about 300 patients, but it's something where we are working as a group of some people. We are trying to find alternatives in order that people can get symptoms under control. But there will be some webinars on that very soon, so I will explain you later on. We still have 2 or 3 patients who should like to give their story. Don't worry, we will come to the main questions which we had, but I would like to try to finalize this round of talks to the patients for a moment. I've seen here Clemens. Well,
Yes.
from Germany. Please go ahead.
Hi, so my name is Clemens. I am from Austria. I'm diagnosed with prefibrotic myelofibrosis around one year ago, a little bit more than 1 year ago. And I'm currently on aspirin and on Besremi. And just for a little bit of background, how it all came to be, around 1.5 years ago, I started having red spots on my right hand, which also after a few weeks turned quite painful. I then went to my primary doctor to get it checked out, who was on holiday at the time. So I went to see a different doctor who, I don't know, the first doctor said she thought I was having a bacterial infection in my hand, which of course turned out to not be true. Then the next doctor said she thought I was having carpal tunnel syndrome because of the pain in my hands. And then when my primary doctor got back from holiday, he got blood work done, and the platelets were fairly high, which they have been for a few years, but this is now the first time where he actually sent me to a hematologist. She immediately got me tested for the JAK2 mutation, which turned out to be positive. Also put me on aspirin right away and got the bone marrow biopsy. And this is where they said, it's most likely prefibrotic myelofibrosis. And she also sent me to a different hospital because she said she's of the opinion that I should be seen by specialists. And they then also put me on Besremi, which I've been since I think 10 or 11 months now, 150 micrograms bi-weekly. And I'm currently seeing my doctor around every 4 weeks or so because he would like to get my hematocrit below 45%. And so I'm getting phlebotomy as well every 4 weeks. Yeah, that's roughly short story of mine.
Interesting. But do you have any big side effects? You have a lot of them, or being tired, or?
In that regard, I'm quite lucky because tiredness, things like that, headaches, I don't really have. The only symptoms in my case are really just pain in my right hand and something like Raynaud syndrome, especially when it's cold, that my fingers turn white, like blood is getting out of my fingers, and then this can become quite painful as well. But this has been improved with aspirin, not gone away completely, but that's pretty much about it.
So basically, you keep on having your normal life which you had before.
Yes, nothing too much has changed for now, which is great, yeah.
Which is good, fantastic. Yeah. Okay. Well, I think you have excellent physicians in Austria, so I think you are in good hands there.
For sure, yeah.
Yeah. May I just make a comment? Typical case. Thank you very much. I 1/3 of young men that are diagnosed with prefibrotic MF and have the JAK2 mutation are usually PV patients, and you have shown it, which is much better as a diagnosis. And so when I see young males below 40 with the diagnosis of pre-fibrotic, having high platelets, I always say, let's just wait for a year. You will most likely have a PV, which is a better diagnosis. And this seems to be your case. And that's why it is so good that you were put on aspirin, because, you know, for pre-fibrotic, you don't need aspirin as a must. For PV, it's very, very important. And that's what I exactly also do. Young male, always put them on aspirin and watch for the hematocrit, because in most of the cases, in the course of time, this is the so-called masked PV. And, you know, so I think you are more likely to be a PV patient rather than a prefab. This is academic, but I think from the prognosis point of view, this is a better story. Just as a remark, very classical case. As I said, if you were with me, I would have said, let's go for a bet and wait for a few months. Yeah.
Okay, thank you. And would you, how would it be possible to then make the differential diagnosis? Would you get, I don't know, 2 or 3 years
Very difficult histologically, you know, because you have a bone marrow that is filled with cells. The erythrocytes, you know, all the red blood cells and their mothers, they are increased in prefibrotic and in PV, and the MIGA, the mothers of the platelets. This should be the main difference, but to be honest, this is very, very, very difficult to differentiate from a pathological point of view. Even the best pathologists argue, is this normal platelets? Are these a little bit, you know, abnormal? So it is very, very difficult. I always say, but we have very nice worldwide data also from Italy, from Spain, that 1/3 of young males, not females, only the young males who are diagnosed as prefibrotic turn out to be cases of polycythemia vera, which is good for you.
That's interesting to hear. Certainly gonna keep that in mind. Thank you.
Clemens, and do you know if there was an EPO level checkout, erythropoietin?
I'm not entirely sure. I can get my paperwork and get back to you in a few minutes if you want to. I could check and see if it was tested.
Because maybe it would help to differentiate between PV and prefibrotic myelofibrosis. If it's lower, but not always, yeah, but if it's lower, maybe it would be more typical for PV.
Okay, yeah, I will see. I only remember that the pathologist who looked at the bone marrow biopsy actually tried to differentiate between ET and pre-fibrotic myelofibrosis, but they weren't sure, and they just said that the specialist has to look at, of course, all the other blood markers as well, and this is what they then told me.
It's really difficult. ET, prefibrotic, or masked PV.
Exactly.
You know, when we put them classically in our presentations, the pathology, it's very clear. But in reality, it is not at all.
Good. All these new cases. Fantastic. Oscar, before you keep on drinking so much water.
Yeah, I was drinking water. Thank you very much for being here, Peter, the doctors, and everyone who shared this story. Before I would start my story, I just wanted to bring up a Corey who wanted to participate, but I think she's having trouble with the links. Just gonna spend like 5 seconds talking about her case. She's a ET CALR type 2 patient, and she had the highest platelets in 3 million. She used Pegasus and got down to 1.7 million. But I think we have a shortage of Pegasus here in the United States, and she's gonna go back to aspirin. And she can't use Besremi because it's too expensive and not approved by the insurance. So she's having some trouble with the medication. And for me, I'm a ET patient. I'm 30. I'm 33 right now. I just turned 33. So I'm a CALR patient. I was diagnosed in 2022. My platelets started rising in 2020, and then I was just on aspirin. And then in July 2022, I started having headaches. I went back to the hematologist. They gave me hydroxyurea. I had been on it for a few months or a year, but it wasn't working because the headaches was getting intense. And I started feeling a lot of fatigue too, like really painful fatigue, just weakness. And my dad at the time told me, let's try go back to China because my family's Chinese. Let's go back to China and try some Chinese medication to see if it works. So we went to China since 2023 to 2024, and during that time I was on PEG interferon alpha 2A, and then with addition to Chinese traditional herbal medicine at the time. But unfortunately, I don't think the PEG interferon was working on me because I had the worst symptoms I had. I was basically bedridden. I couldn't really walk or do anything. And a lot of headaches that would keep me up like 24 hours awake. And I just saw a chest pain after being tired. Eventually, I moved back here to New York. I stopped all medications to see what was working, what was not. And then my doctor here in Mount Sinai, Dr. Mascarenas, John Mascarenas, he gave me a clinical trial of methotrexate, 15 milligrams per week every Thursday. So I started that in April, and I have been feeling better. The best I've felt since probably 2022, with the exception of the past month, because I have been feeling a lot more fatigue and just painful suffering, all of that in the past months. That's why I've been missing Simon's qigong class, because I've been going through some symptoms. But yeah, that was our story, me and Corey. Yeah, thank you.
I just want to add for a moment. Did you talk about your clinical trial you're doing? Yeah.
Yeah, so it's the methotrexate trial. I think it was traditionally used for other blood conditions. I'm not really exactly sure, but they wanted to try that on the ET patients. So I was the participant, and I have been on it since April.
Did you know about this clinical trial? Because I never heard about it before. I only heard it from Oscar. Does anybody has experience on this kind of trial?
There was a presentation to open in the UK, but it wasn't open at the end. But yeah, I'm talking about, God, probably 5 years ago, after COVID, around COVID time or after COVID, but we never opened that one. I mean, we know it's been used for a long time for rheumatological disease. So it probably what we mentioned before about the inflammation, but I think we have to wait for all the results, because I have not heard anything.
Haifa, did you hear anything? No?
No, I know about the trial, but we didn't participate, and we have to wait for the results.
Mm-hmm. But
You know,
I don't
it's
think
an academic trial, investigator-initiated trial, not from a company. And so usually there are only a few centers participating, and most of these studies are local. So we have to wait for the data.
Yeah. So in Europe, it's not known, basically, no?
No, we know methotrexate.
We use methotrexate for different diseases, but not for MPN.
Yeah. ET.
But this is a problem of interferon tolerance in some patients. And this is why we've got the combo trials when we use interferon plus JAK inhibitors. And it seems that it works better when we use both of these drugs because interferon is much better tolerated. And yeah, so that would be another alternative for this interferon, if it's used in much more advanced phase of disease, may provoke additional symptoms. Sometimes patients, they have really severe pruritus. They've got a headache, they got fever. So in I've got one patient now. We started with, I mean, she was treated before with hydroxyurea. She didn't tolerate it well. Then when I take care of her, I start with interferon, and it was horrible. She was not able to take it. We tried with Pegasus, then with Besremi, none of them. And then I decided to put her on Besremi plus ruxolitinib, and she's getting better. I mean, she's not having this itching, she's not having these headaches like before, bone pains. And yeah, I think that it would be another options for this kind of patients.
we do have a few on combination as well.
Yeah.
They control, I guess they do control different things, right? You maybe have a better response in symptoms for one medication and then bloods from the other. So the combination, it may be helpful in some patients.
Good. Thank you very much. Only two people left. Emily, can you try to tell your story?
Yeah, mine's actually pretty straightforward. I'm 35. I was diagnosed last November, and I've been having aura migraines for about 10 or 11 years. Very sporadic at first. I just thought it was from dehydration, so I really didn't think anything of it. Also some fatigue, but again, I was just very social, and I thought I just wasn't getting enough sleep. 2023, I woke up one day and for 6 straight months, I had debilitating migraines. No idea what it was. Went to a chiropractor. They said I had a compressed spine, so they're saying that's what caused it. Went through physical therapy and that treatment. It seemed to help a little bit. And so just kind of forgot about it. And then last October, my doctor was like, have you ever had blood work done? Like, you're in your mid-30s. I said, no, never had a blood panel at all. So we had one done and got a call that my platelets were high. I had no idea what that meant. I just thought, okay, like, I must be eating something. I don't know. And they referred me to a hematologist. She said that with the high platelets, it was matched up with ET. And when I got all the genetic testing done, I had the CALR mutation, had the bone marrow biopsy, everything lined up with ET. She started me off on aspirin, didn't do anything. Started off on hydroxyurea, and that has actually lowered my platelet count from about 900,000 to, as of last week, it's about 320,000. So within that normal range. So I'm responding to it really well. And yeah, headaches are gone. I just have like itchy symptoms, so that's about it for my reactions, I guess.
Yeah. Is your quality of life today very much influenced by the symptoms?
I actually have a ton of energy. Like Simon said, just being on this chemo has given me so much more energy. When they first said chemo, I too was like, I'm going to lose my hair. This is insane. Like, no. But it has just helped me so much. I've always been active my entire life. I run half marathons, weightlift, and that has truly been a major outlet for me to get through this as well. So I'm very much an advocate for staying active.
It's many patients. We really have a long time to come to a final analysis. So we have been living there during many years with illness, and we didn't know about it. I think in UK this is not such a long way normally to find somebody, or do you have the same experience?
Well, I think I think in general we've seen like it's not that difficult. I think our GPs, the moment they have a blood test which is of normal contact with us, immediately we have many ways to bring the patients to our clinic, literally probably 2 weeks since you have your bloods done in some cases. It's just sometimes the time to, like, when you request the bloods, the JAK2s or the CALR, from the lab. But again, in 2-3 weeks, you should have a result. So realistically, I guess we'll say month and a half, you probably have a diagnosis. Ish, depend obviously on the situation. But the other thing I was just going to say, and I don't know if Marta and Prof agrees, I guess we're seeing more and more young patients now because people like Emily or any of you guys goes to the doctor. Sometimes they do bloods because of work, and they find that this, and they just say, oh well, this is abnormal. So there is two things, probably more tests, more education on the doctors to thinking actually this is abnormal, and more education on the patients to say, hold on a second, this is out of the range. There's something going on here. And then this is my personal view, but obviously I've been working on this only for like 13 years. Well, Prof and Marta have been longer than me, but I think we are making more and more diagnoses in young patients because people has more access, which I guess it will change, right? We're making, again, we're talking about treating, but we are seeing the patients before they have come with a problem, in most of the cases. But yeah.
I mean, generally in Poland, GP doctors send everything to hematologists. I don't know how it's in Germany or in UK, but it's really crazy because sometimes we have to diagnose healthy people. Yeah. So this is too much. But yeah, in that way, we may diagnose disease at very early stage because they are sent it to us very early. But on the opposite way, many GP doctors, they are not doing morphology tests. So this is a problem that sometimes patients are having symptoms and they do not do blood tests for many, many years. And this is a problem why MPN are diagnosed late. I would give you an example of my patient. She had Budd-Chiari during pregnancy. Then we diagnosed her of PV. And when her baby girl, she was like 4 years old, she started to asking pediatrician if she has ET, because she was all the time with her hands around her head and she was afraid that she had headaches. And nobody did morphology till she was 10. So once they did it, it appears that she's got like 2 million of platelets and she was diagnosed with ET. So sometimes I think that, and this is what I teach my students, we have to listen what our patients are trying to explain us, maybe not in a very scientific way, but yeah, we have to listen and we have to ask questions to do diagnosis as fast as possible. Yeah.
How do you experience in Germany, Haifa?
We have a terrible system like the United States. A university is a tertiary referral site. The general physician has to refer the patient to a hemato-oncologist. They treat everything in clinical private clinics. And only these hemato-oncologists who treat colon cancer, breast cancer, everything, they then refer the patients to us. So most of the time, unfortunately, in Germany, we see patients with a lot of complications. And the dilemma in Germany is that, whenever there is a drug approved, Germany is the first to have it available. So, you have one patient with myelofibrosis in the clinic, then let's say momelotinib is approved, then the patient gets momelotinib, although the doctor really doesn't know much about the drug, the adverse events. So in Germany, at universities, we mostly see really the complications, which is really sad. It is getting a little bit better thanks to the patient network. We have a very active, the German MPN network. And through them, you know, the patients are getting information and they come to see universities and special clinics for MPN earlier. But generally, it's a disaster.
That's the difference between the health systems, right? Because Spain, I don't know how is the situation in Spain, Peter.
No, Spain is centralized.
No, I
This
know.
is the US and Germany.
Yeah. No, I know, but in terms of how long it takes for the patients to go to the specialist, hematologists consider this waiting list quite long.
I
I'm
think
not sure.
it depends. It depends where you live.
Yeah.
If you have a luck that you live in Barcelona, Madrid, Sevilla, it's most, I would say most of the general doctors when know when we have an MPN patient or we might have an MPN patient. But still, I think it's not more than 6 months ago I was at a general doctor for something else, and I told him that I have Polycythemia Vera, and he asked me, "What is that? Can you write it down for me?" For such general doctors, and he said, "Well, I've never had a patient with Polycythemia." And I couldn't stop. I told him, "I'm sure you had him, but you didn't recognize him." So this is, let's say, the biggest problem we have. And obviously, if you live somewhere on the countryside, inside, it's becoming very difficult. It's the same situation which you might have in other countries where I think even you go to the States. The States is they estimate over 40% of the territory of United States. They have no coverage for MPN, so you have no MPN specialist. It's very difficult to find the right doctors. I can hear it, from the stories which we're getting from our patients. That simply they have been living X years before they finally managed to come to a real MPN specialist. I mean, some things is because we have learned more. Today we know much more than we learned 10 years ago. For example, I know in the meantime that I had it since I was very young, maybe 10, 12 years old. And I had episodes like erythromelalgia, and I went to X doctors, and I had very good doctors. I lived in Switzerland these days, and we didn't find out what it is, erythromelalgia. Only maybe 20 years later, my hematologist told me, "No, this is a sign. If you have erythromelalgia, it's a sign that you most probably have MPN." So it's just a knowledge, and I think this is something which we have to face basically everywhere. But it's like in Germany, you have your big centers, for universities. In Spain, we have in the big cities, we have a very good service. I think UK is a little bit an exception because it's more spread out. It's also thanks to MPN Voice because they're making their local meetings and etc. So we are trying in the other countries, the same thing is happening. And I think in all the countries where you have a strong PAG, the knowledge of a patient is becoming much better. And then obviously we have our problem of languages, when you go from one country to another. But it's I would say for 60-70% of the patients, they have a long way to go until they finally get the final diagnosis.
I'm lucky because I was working in Spain, in Galicia, and now I moved to the other place in Poland. I'm still not in Wrocław, Peter. I'm working in Bydgoszcz. No, I'm already in Bydgoszcz, and
I see.
This is change that I need to manage now because in Spain, in Galicia, we've got many hematological centers. So the access to hematologists was better. Then I go to Wrocław, to academic center, and we covered a big region, but we were a huge hospital, and it was really good control, and patients really could come to us to have a visit very, very fast. And where I work now, in this region we have so low amount of hematologists, and the problem is getting worse because the majority of hematologists are at age of 50 or 60, so they are going to retire. And we have like 2 years of queue to attend the patients at hematology clinic. So this is a problem. Of course, we try to select those who are more urgent to diagnose, for example, acute myeloid leukemia in short time, not waiting 2 years because it's too long. But this is a problem that we need to manage now. And I think it's the same in whole Europe, that we don't have enough amount of specialists. And as I said, in Poland, at least GP, they are not working good. I mean, they are sending everything. And if we have to manage diagnosis like GP, so we are not able to take care of hematologist or oncologist patients only. Yeah. So this is what we ask our Ministry of Health to change the system, because GP need to do much more work to help specialists to work with really sick people.
Yeah, it's definitely depending on the system. There's no question, but to change a system, it's not easy. I mean, you have more direct access. For us as PAG, we are, I'm involved in most of the countries with politicians, but it's not easy. But anyway, okay, we're still missing Aroa. Now, the people who doesn't understand Spanish, Ingrid, can you explain them again how to do it in order to listen to Spanish?
Yes, you have to click down on the Zoom bar interpretation and then choose interpretation into English.
That's where you have a globe, you have a round globe.
Yeah.
Ok. Bueno, Aroa, te toca. Perdona que te he cogido como
Ya,
última.
sí. Hola,
pero
hola de
bueno.
nuevo. Primero agradecer todos los testimonios, porque para mí, como madre de una niña de 11 años con policitemia vera, pues es muy importante ver a personas jóvenes como vosotras, con unas, no sé, que os veo bien, ¿no? Con buenas vidas, que estáis, que seguís hacia adelante, que hacéis deporte, que trabajáis. Para mí eso es muy importante. Veros a todas vosotras me da esperanza. Y luego también me sorprendió mucho el planteamiento de este encuentro cuando leí 20 años versus 60 años de tratamiento, porque desde que diagnosticaron a Irati, a mi hija Irati, eh, he tenido la angustia de pensar que morirá joven. He pensado mucho en eso, porque hubo una de las hematólogas que le atiende, me dijo una vez que, bueno, pues que con suerte viviría 20 años. Ella puso una fecha, ¿no? Una fecha de caducidad. Y, y es algo con lo que tengo que vivir, porque sí que, pues diría que vivo muy en el presente, disfruto de ver que mi hija ahora está bien, pero también sin olvidar que hay un camino, ¿no? Por recorrer, y un camino de enfermedad, con una enfermedad crónica. Y entonces sí que me preocupa mucho, y os lo pregunto a las médicos y también a las personas que tenéis la enfermedad: ¿qué pasará cuando mi hija mire en Google Polycythemia vera y lea que tiene una esperanza de vida de entre 15 y 20 años? ¿Y cómo le voy a poder explicar yo que eso solo vale para las personas mayores, o que no, o que eso no va a ser así para ella porque tiene tiempo, porque va a haber tratamientos? Me gustaría saber qué mensaje podría darle yo a mi hija como, o sea, y me gustaría un mensaje desde la medicina, y también un mensaje como paciente, ¿no? Como persona con policitemia vera. Y esto un poco es lo que lanzo.
Okay,
Aroa.
we can let's answer in Spanish, in English. Sorry, so
In English.
Aroa, she will get it
Sí, sí.
translated. But first thing you can tell them, but you know a man who is diagnosed since 35 years, and that's me. You know, I have it since 35 years, and you know, I assure you, I will have to die, but it's no question. But I will not die from PV. If you take the controls, if you need a little bit of luck, but you have not a too aggressive PV, you can tell that you know people, but you know they're living like normal, and nothing will happen. Which is one thing which I personally can tell you, but I'm sure Marta and you know yeah, Haifa and Natalia, you can give your point of view also.
If I can start. Aroa, this girl that I told you about, the 4-year-old girl with headaches, now she's 35. She's okay. She's on interferon. She's got her own child. So yes, the long-term survivor of your daughter probably would be a little shorter. But with new drugs arriving, we have a really hope of improving the survivor of these younger patients. And this is what you have to think, and this is what you have to explain to your daughter. An example of Peter, an example of my patients would be helpful for you to explain to your daughter that her life should be at least, I don't know how to say, it should be quite normal, yes. But of course, with some drugs that they are coming, maybe we can improve it even more.
Yeah. In addition, I have two or three points. Number one, everything that is in Google, I always say, don't ask Dr. Google. It is, you know, what is published is already old. We are in a dynamic process. So when you read something, it is already too old. So nothing what Dr. Google or whoever says is actual. Number two, PV or MPN generally is so individual. Every person is different from the other. So if I have a bad experience with, you know, heard or know somebody, this doesn't mean that you will be the same. So it is very, very individual. And third of all, and this is important, I always say, when you are an AYA patient, a young patient with it, you will always remain an AYA. This is very interesting. As I said, these are two different diseases. We have a study and we have now submitted to a Congress the data. We have patients who are, let's say, 60 or 65, but they had the diagnosis 30 years ago. And their features, not only clinically, but also from the inflammation and everything around, is exactly like somebody who is 20. So this is also, as I said, individual. And I always say, once AYA, you are always AYA, which is good.
If I just reinforce that message that as Peter, we all have patients that have been on this condition, 30 plus years. And I think what is important is your daughter is already on a treatment that we know it can have an impact in a positive way on control the disease, maybe reduce the JAK2 mutation, maybe, so much data for the PEG interferon. She's on PEG, right? I did write that correctly. She's on PEG at the moment. It's on PEG interferon. So, and on PV patients with PEG, we have so much data coming from that in reducing the JAK to change the way the disease behaves. So if we start with her young, we may be able to have a better outcome in control that disease. Obviously, no one is going to take away the concern. It's impossible. And with all the data that is, you Google it and it's just like terrifying. but I will advise her to go to like, MPN Global or MPN Boys, whatever, patients group that is the data that is there is proper data, if that makes sense. And as we've been talking with all of these new therapies that we have in, there is a massive future for your daughter going forward. We are trying our best to get better. I mean, I was just to have to finish to read an abstract that we want to submit with Marta group. I know they're in a meeting that we have to submit before tomorrow for the European, and it's all talking about young patients. So we are doing all our studies to make their life better for your daughter and and everyone here right now. So, and the kids that will come and the young patients that will come. So I think I will say we probably are more. I mean, we can't predict the future, but I think it's different now. And as hard as it is for you and your worries, which is totally normal, right? We all will be in that position. When we're hearing you, I think we're all feeling the same. But I guess it's different the way that we treat and confront this condition because we know better. So I think there is, with all the precautions we have talked as doctors.
It is huge, the difference, which we, even compared to 15 years ago, when I got, I was in the first times I was in meetings with physicians, so I always said for me, MPN, when I got diagnosed, it was like a big black hole. There was just nothing there. And I would say today was a big dark sky, because the difference what we have today is that we do have many skies, which means the new products which are coming up. And I can also tell you that my first hematologist which I had, he told me that I have when I was 48, and he told me that you have 5 years to live, which I obviously did not accept, and I simply changed the doctor. But this is, and the changes we are having in the last 5 or 10 years, they are simply fantastic, and there's so many new products coming up. But the future for young people, I think, is excellent. It's really, you will have treatments available. I think we're very close to come at least to chronification, and then to in order to that we can really cure the whole illness. I mean, let me put a question to the patients which were here. Are you worried about your future? I mean, are you worried to die? Are you worried that your life might be shortened because of the illness? Sasha, you always have opinions.
Yeah, so I think that when I first got diagnosed when I was 17, there wasn't a lot of information. This was almost 17 years ago. And at first I was very worried about, am I going to survive? Like, because I looked online, I know I shouldn't have, and it said there was like very short amount of time I had basically. And I was super worried. Like, I was constantly thinking about the future. Then for a while, I went through a rebellious phase that I'm like, I don't care if I die. Like, it's okay. I like make it happen type of mentality, which was not healthy. But now it's like, yes, it does cross my mind sometimes, but I don't let it like eat me alive or consume me, because it's like then you can't enjoy like the little things on your daily basis if you start thinking about like, okay, I don't know if I'm going to be here next year or in 6 months. Like, because like I always tell my family and my friends, anybody can die at any time. And it's kind of that mentality of just don't worry about it. Not everybody's thinking like, I'm going to die tomorrow. Like, no, it's like enjoy it every day. And that's how I'm seeing it now. There are some days that are more difficult than others, I won't lie. But I feel that now I'm not really obsessed with this whole idea of I'm going to die. It's just taking it day by day.
Thank you very much, Sasha, for your open opinion. Anja, do you have any opinion on that?
So I have a similar opinion because I've been living with it for like my whole life. I always knew they had a high risk or like a higher risk of thrombosis. So I knew that since I was a child. So I had a long time to think about that and deal with that. and I think I've accepted it that I probably won't die from this disease, but we all have to die of something. And I don't know, I'm not worried about it, even though 2 months ago I found out that people with my disease can get myelofibrosis or acute leukemia. I wasn't that shocked. I don't know why I'm not shocked, to be honest. Yeah, currently I'm not worried. I try to live a healthy life. For me, like as we already discussed, doing exercise, eating well, it really helps. Yeah, right now I'm fine.
Good. Emily, you have some opinion on that?
Yeah, I don't know if it's just because I'm so newly diagnosed, but like in my brain, like everyone's saying you have to die from something, but like it's just like it's not computing that like I'm going to die from this. Like I'm just like I don't know if it's denial or whatnot, but every day you got to take it day by day. And like sometimes just because my symptoms like I don't have any from, the disease or taking the medication, like I sometimes forget I even have it until, I need to take like another medicine for something. I'm like, oh, I need to like check with my hematologist for that just in case. Or if people talk about like their future and like family planning, it's like, oh, well, I'm going to have to like struggle with that a little bit. So whether or not like I think about dying from this, like it's just, I don't know, like it's just, I haven't really thought about it that way yet.
Great. I think it's fantastic attitude. Absolutely. Milene, are you still here?
Yes, I'm still here.
Yeah, okay. Did you
Have I
listen?
no?
Yeah.
Yes, I did. Yes, I did. No, I think I'm not like scared to die from this disease. No, but I have been thinking about the future, and just like Emily said, like sometimes you think about, well, I think about starting a family since I'm 29. Not like in the upcoming year, but maybe in like 5 years from now, 3 years from now, and then yes, I think about the consequences of the disease. And also because when you're starting a family, you have to, well, take care of a kid and the whole household and everything together. And that's something that sometimes pops in my head, like how am I gonna manage all this when I have these symptoms?
Yeah. Good.
But not
Fantastic.
scared of dying, no.
Yeah, yeah. I don't ask Oscar because I know you're not afraid. Right?
Well, I only think about it when I had really bad symptoms. I'm worried whether I should go to the ER or not, the emergency room. But then after I pass, I'm okay with it.
You'll make it. Don't worry.
Yeah.
We will keep you busy so you don't have time.
Thank you. Thank you. Yeah.
Okay. We have already 2 hours behind us. I don't know. Does somebody want to make a break for 5 minutes, or shall we just go ahead and maybe try to finish a bit earlier?
Break 5 minutes.
Is it okay? Yeah. Do you want to make
I
it?
have to put off the light.
Okay, let's make a break for 5 minutes. Get some water or whatever you like to have, and I'm back in 5 minutes. Okay, so everybody comes up. See, it's good. Clemens, are you here?
Yes, I'm here.
Clemens,
Sorry.
you wanted to check some analytical data, no?
Yes, just to recheck, Dr. Sobas, it was erythropoietin, is that correct? Yeah. Okay,
Yes,
so
exactly.
my levels were 3.6.
Yeah.
They are low, very low.
In between, yeah?
On the low for us in the lab.
No.
Not too low, but
Clemens, can you stop your micro?
Sure, sorry.
Yeah. Go ahead. Natalia or Marta?
Oh, I was going to say that from our lab is on the borderline low levels. I think we are at the below 5. So yeah. Marta, I don't know if you want to.
Yeah, it would be the same in Poland. So it would be low level. So it could be more PV than prefibrotic myelofibrosis. Yeah.
Okay. So I would like to come back to our original program which we had. And the next point really was family planning and pregnancy. Now, it's a huge point, obviously. It's very big. And but I would like to we have a certain discussion or talk in between the patients and our physicians. I know about family planning obviously is a big question. You're young, you have to plan your life, and normally you are at the age, you have a boyfriend or girlfriend, and do I have a family? To create a family, I remember we had a very good friend in Germany, and he actually decided to have a child earlier than they had planned it because he had myelofibrosis. So he said, I better make a baby now and I still can do it. I don't know how really to start this question because it's something which obviously for me as a man it's not something which is it's important, but I would probably leave it up to my wife, but she has to say what she wants to do. And I think here it's the same thing. We have to leave it to the patients. First of all, you as physician, I'm sure you have been confronted with these questions, patients who are asking you. What do you suggest? I mean, what kind of tips or what kind of ideas or what should our female patients do?
For males, there is no problem. They should, they could father a child with or without treatment. It's fine.
Yeah.
Even if it is ruxolitinib or interferon or no treatment, for men, it's no problem. And even today, for females, generally, it is not that big a problem. We know from the data that the risk for the mother and for the baby to have a nice and successful, pregnancy and a healthy baby, untreated, it is about 1/3, 30% the chance less compared to the normal population, to the normal pregnancies. But with the availability of aspirin, we have anticoagulation with low dose heparin and interferon. We know now from the data we have that the outcome for both mother and child is almost comparable to that what we know for the normal pregnancies. This is particularly true for ET and less for PV as well. And for myelofibrosis, it's a little bit more complicated because, we don't have that many data because myelofibrosis is not that common in young patients. So we don't have that many data. But, I have many patients with severe thrombosis in the abdomen, like Sasha, with big spleens. And we have gone together. I always say these are my babies too, because we plan them ahead. And I have really a very young lady with huge thrombotic events in the abdomen. And now she has 2 well and healthy babies. So we can do this much better today than, let's say, 10 or 15 years ago.
Yeah, the only topic that I would like to add is what Haifa said, planning babies. Yeah, this is important.
Disculpa, es que me emociona escucharte porque siempre he dado por hecho que Irati no podría tener hijos, porque tiene un cavernoma portal y tiene una esplenomegalia y siempre he pensado que no podría tener hijos.
No, this is not true. She
Lo había
was
dado.
able to have it, yeah. But we
De
have to
hecho, me
plan it.
dije, o sea, creo recordar que fue algo que me dijeron en el hospital, pero no puedo, o sea, ahora no puedo, pensaba que no.
Well, I think
They
all
can.
doctors will agree to you that she can.
As Marta said, it's planning, planning, and planning. I hate it when, when the patient comes pregnant, we cannot do much. And then the risk is very high, that something will go wrong. But with the patients, we plan together. And really, for example, we know that losing a baby in the early pregnancy is much higher for low-risk patients, even because, the placenta and the blood supply to the baby is not that good. So we plan to introduce interferon. And I hate to introduce interferon during pregnancy, because we don't know the adverse events, the tolerability. So it is very nice if they give me a few months to start with interferon, control the disease, put the patient on aspirin or low molecular weight heparin if she has thrombotic events, and we do the ideal situation, and then it works in the majority of the patients. It goes perfectly well.
And besides, there is another topic that some of drugs like ruxolitinib shouldn't be used during pregnancy. So this is why we are insisting on planning. Yeah, so we have to put good treatment before pregnancy. We have to plan it. We have to discuss the problem with gynecologist. How should be baby delivered? Gynecologists should be also be aware of this disease, how to manage it. We need to check out both gynecologists and hematologists, and it should be okay.
My add in top of that is, I mean, I'm totally agree. It says we can plan in, and we have, as Prof say, a lot of babies with our patients, isn't it? Because we have that, and I think it has changed significantly as well the way that obviously obstetric teams or gynecologists manage as well the patient, and obviously in general, I guess depend on the country, right? But there is a clear shift to have babies old. I guess I hate the word. Consider old over 40. I'm not buying that one. But again, in that aspect, we know how to manage, and it's getting better to manage in general those patients. But the other thing I was just going to add is for those women that want to have IVF, again, is something that we can plan and we can work together, because I have so many cases of women having IVF, and we just in vitro fertility. So we give them interferon, we give them aspirin, we manage during the process of having the stimulation, because that's in any patient, independent of your MPN, increase the risk of a thrombotic event with IVF in general. So obviously you just need to plan that in advance. And if I give you a case of a myelofibrosis patient, 47, been diagnosed for I don't even know how many years, high platelets, has 4 kids, and the last one was last year with IVF. So the last 2 were IVF kids, and she's 47, and the baby's gorgeous. Like, I saw her during the they have to admit her for a complication from the pregnancy, which is pretty normal, like hypertension with the pregnancy, which is nothing related with the MF. They manage, they want to keep it in. I have a long discussion with her to put it on PEG interferon, and she was like, no, I have the babies before with the same number of platelets. We plan everything else. Baby born absolutely fine, and it's just a gorgeous baby. 1 year now, because it was about February last year, and absolutely fine. 47, so I'm 4 kids. Well, 2 of them are not kids anymore. They are probably quite teenagers now, but you know, I think it has changed significantly the way that we manage. It's possible. It's just planning that as everything in life.
But maybe we should launch also the message to those women who are already pregnant that we are also able to control the disease. It's not impossible. Yeah. So of course it's better to plan before, but if it happened, because sometimes it happened, so we are able to control the pregnancy also. So.
And I guess the problems later in terms of getting up in the middle of the night to turn the nappings and giving them, you know, food, that is a standard problem. So that's something to manage. But that's a standard mom problems, isn't it? So, but yeah. The only thing you probably, well, I will say, I mean, I don't know how it's in Germany and in Poland or even Spain or other countries, but in the UK, again, probably our hospital is quite lucky on that. But we do have a clinic together with. I have one colleague that actually look on these patients. So we call. I call it the VIP clinic for pregnancy patients because they go there, they see a hematology consultant, and they have the obstetric team, and they have more scans like every month. You know, you are more like VIP basically. So it's slightly different maybe in other countries, but it's just, and the obstetric have really good guidelines now. They're really standard guidelines around the world. So
you're living in a beautiful country, Natalia.
Well,
the
not in terms of food, but in terms of MPN in guys' hospital, probably yes.
I'm talking about in relation to MPN.
We're conscious that we sometimes obviously have that privilege, and it's just teaching other colleagues how to manage these. And I think it's important the patients ask those questions, and you know,
we couldn't have that service in Spain. I can tell you for sure. But anyway, we can try to improve and come to your level also. Well, thank you very much from medical side. Now, I would like to hear about, the patient's opinion. I mean, you are all in the age where, maybe you have a girlfriend, boyfriend, they want to create a family. What do you think about it? Emily, can you maybe start?
Well, I actually have a few questions too. One of my questions was about IVF, so thank you for answering that. That gives me hope. For if and when I become pregnant, is my hematologist is that sufficient enough, or do I need to find like a specialist in the MPN world to help with the pregnancy?
If you have a good doctor, it's okay. And my opinion is we don't have this good communication with the obstetricians in Germany. And I always say, if you have a good hematologist, then I think from my point of view, at least in my experience, it's more than enough.
Okay, thank you. And then
because obstetricians will be like the doctors of Peter. They we tell them ET or PV. They say, "What is this? I don't know this."
Yeah. And then you all talked about deliveries. Is there a preference that you all have, or is it just person by person, how they are at the time of delivery?
It's person by person. For example, those patients I told you, the extreme case I had with a severe thrombotic event in the abdomen with a big spleen, I really insisted on a cesarean section. But on the other side, we have women that do not have these complications where a normal delivery is perfectly fine. So it is case by case.
Okay. And then is there a possibility to pass this down to the baby?
No.
I think that was all my questions.
Marta, any comment?
Just one, maybe, because my work at Bydgoszcz started with not very nice case of acute myeloid leukemia, pregnant acute myeloid leukemia. And this was the point when I get to gynecologist in my hospital and I said, hello, there are sick women that they may be pregnant and we need to work together. And what I do, I describe everything to my patients and I try to convince them that they need to show this explanation to gynecologists. This is one point. And second one, I try to reach out to gynecologists to explain them what's going on with my patient. So maybe this is also it's working. Yeah. I mean, at the beginning it was difficult because it was like Haifa said, ET, what does it mean? PV, what does it mean? And what's the problem to treat acute myeloid leukemia during pregnancy? What I'm worrying about. And now it's changing after 1 year, because this is on 1st of March, we've got first year anniversary of working on my new department. And now we've got a really good collaboration with obstetricians, with gynecologists. So maybe give information to our patient, give information to gynecologists would a little be helpful to manage the pregnancy.
Good. Anja.
So, to be honest, I don't really plan on having kids. So it's a pretty easy question for me. Even though I know that if I would have a kid, I would probably pass it down, because if I understand it correctly, my disease is autosomal dominant. But since I don't want to have kids, I think I'm lucky in this question. Yeah.
Go to the human genetics. They will tell you exactly the risk for the babies, for the children. This is a very important issue as well.
I will do that.
Yeah.
Sasha, what do you think about this?
Well, this is actually something that I feel that, when I first got diagnosed, I did ask about this, like, what are, the chances of me having a healthy pregnancy? And they basically told me, like, no pregnancy for you. You can never get pregnant. Don't think about it. It's not going to happen. So for many years, that's what I thought, until recently that I was explained, like, it is possible. It's not going to be an easy road. There's going to be complications, maybe, but just like any other pregnant person, you just have to plan and prepare for it. Which, I've had a conversation with a gynecologist about this already, and she kind of explained the options, and my hematologist is aware as well, like, what these are the options, so then I can make kind of a decision. But I do have a question though. So for example, there are medications like Hydrea, and I don't know about the rest, but I know specifically Hydrea that they say that it can affect like your like if you're able to have kids in the future in the long run. So for somebody that's had Hydrea from a very young age for like 10 years, are there any studies that show that like the probabilities do get lower, or has this kind of been improving, or I'm kind of lost in that sense? I don't know if my question makes sense.
A short answer, not really from our experience. I don't believe that treatment with hydroxyurea in the past affects the pregnancy, but hydroxyurea under pregnancy is not that good. But from the experience from the Egyptian physicians with whom I have a lot of contact, there is not available classical treatments we have in Europe. They give their patients hydroxyurea even throughout pregnancy. And they say that it is completely safe even throughout pregnancy. This is something we don't do in Europe, but even there, they seem to have a very good experience. We never, if you are on hydroxyurea, we don't encourage pregnancy. We would like to change. But even then, and the previous history of hydroxyurea is, to me personally, not a big issue. as I said, I have a small, I always say my small army of MPN babies. I always say they are my babies as well. So no, and most of the patients had hydroxyurea at some time in their course of the disease.
Okay, thank you.
Yeah,
I've got also.
Sorry, sorry, Marta.
I've got also patients with hydroxyurea with children, so yeah, it's possible. And this is what we're talking about planning. So sometimes it's impossible to plan, and women got pregnant, and she didn't know that she was pregnant because she was almost 50, and she was taking hydroxyurea for a long time during the pregnancy, and the baby's okay. So yeah.
Yeah, I was just going to say we have patients with hydria. Obviously, if we know and they're planning, we sometimes say if it's safety, maybe stop and then try to change to PEG if they need to be on a treatment. But I also remember in top of my head a couple of cases, patients with ruxolitinib that has become pregnant. In one case, it was the male that have the ruxolitinib, and the other one was the female, and we just stop it because obviously we don't have much information, but babies are absolutely fine as far as I know. So.
Okay, thank you so much. Yeah, it's something that I've always had like doubts on, and kind of it caused me a bit of fear of like, oh, this is going to mess up my body in the future. But that's good to know. Thank you. I don't have any other questions.
Thank you, Sasha. Milene.
I'm sorry, I'm also cooking, by the way, because I'm a bit hungry already.
I thought so, but it's smelling very good.
You should smell it. I'm so sad that you can't right now. Well, I think I'm a bit more relaxed now since I'm hearing all your stories, so that's a good thing. And I had like a couple of months ago, I talked to a gyno about maybe getting pregnant. Yeah, about maybe getting pregnant in like a couple of years. And then she told me that maybe it's a good idea to, how do I say this in English? Put your cells in the freezer. Then you know what I mean, right? But now since I'm hearing your stories, I don't think it's actually necessary. So maybe you can give me your opinion about that.
It is not really necessary to do cryopreservation.
Yes, that's the thing.
But it is not usually necessary for ET.
Good.
Or PV.
Yeah, no. Well, then I think I don't have any more questions. It's just not about the pregnancy. It's just that I'm thinking quite often about how I'm gonna manage all that in the future when my symptoms will get worse. But it's really hard, of course, to say how it's gonna develop in like the long run. So I think we just have to figure out and wait.
Yeah, I think I can tell you from and I assume well, Haifa, she said she has many babies. You must have more experience than I have heard from our patients. They manage. It's when you have a baby, and even when you have more symptoms, one or the other way, you find a way to manage and to have a baby, and keep it growing, and then we have even a second one despite of the problems. Is that right, Haifa?
Absolutely. Particularly those with thrombotic and big spleens and varices, what Sasha said in the gut, these are also a challenge for me. And by joke, I always tell the patients, before you want to get pregnant, tell me so I can run away with a joke. But, we go together and, they have also the symptoms you said, but, you grow into this. And if you have a good hematologist and, they manage. This lady has now 2 babies and she's perfectly happy. When she said the first pregnancy was not that easy because the gynecologist didn't understand why I was insisting on a cesarean section. in a healthy young woman. And then they had to do the cesarean section. The second time they were very humble and they listened. And so the second pregnancy was very easy and straightforward. And, they grow into, having kids is never easy, but this is enrichment and you will manage.
It's just, what I mean, at least I can remember, what when our two kids were growing up, I mean, the man, he has, the luck that he can go out for work, and we have, at least a few hour rest. But for a woman, I think it is very stressy, to grow up children, and the more they're growing up, the problems are growing. So, I think the biggest problem, which most probably this young people has, is but now I'm okay, but maybe, in 5 years or 8 years, I have more symptoms, and, then I might not be able to do it. But I think this is also something which you must have experienced, the three of you, but you have patients where they have an increased symptoms, and they have kids which are 6 years, 8 years, or 10 years old, and one of the other way we find to manage to find a solution on it.
Sure, but everything can happen in 2 years and 3 years. Who knows? Nobody knows what is, and we try to find a solution whenever we get a problem. But I always say statistically, the probability or the chance that something will happen when you go into a car to get a car accident is statistically seen much higher than that you are likely, I don't know, that you will get a thrombotic event or whatever. So, nobody knows the future, and we have to do what we think is right and do the best. And mostly it works.
Besides, we have to think that this is chronic disease, and we have to treat it as a chronic disease, because when I've got a patient with ET and she's got also diabetes, hypertension, she's not afraid of these diseases. I mean, and I ask her why. Because you can have also thrombotic events related to diabetes or hypertension, and you are not thinking about this disease as severe as ET. So I think it's point of view. You have to live day by day. We are going to do what we can to give the best quality of life. And this is chronic disease, and that's it.
Oh, thank you.
Totally agree. Totally agree. And as we've been saying, there is so many ways that we manage this now different than we managed before. And in general, if you think about the way that we manage hypertension or diabetic now, it has been revolutionary. Now people live longer. So what would be a different, right? I have a lot of patients with Mounjaro now. And you can even see there are some of the symptoms as they started and losing weight, and they're able to do more walk and not getting breathless when they walk 4 floors to our clinic. It's a different. So that's probably also has an impact on all the cardiovascular risk factors, risk of thrombotic with their ET or the PV or their MF, and this has a positive impact. So things has changed so much, and you have to just understand this is adapting, isn't it, as we've been mentioned? But planning is important. That's I will mention that. And if it comes, then we'll manage and we'll want to pick to later on. So baby, that's fine. It's always happy days when you have the babies coming to the clinic. It's more fun. So yeah.
Absolutely.
Besides, you can think that being a doctor and working on nights and having babies is not so easy, neither. So I can tell you, because I've got 2 and I was doing night shifts and it was really heavy. I know that this is not the disease, but you have to treat your disease as a chronic disease, and you have to live as full as possible, and that's it.
Absolutely. I think Ingrid, she is taking care of the questions which are coming in. And Ingrid, I think we have one, yeah?
Yes, there is a question of a patient that says that on the topic of planning pregnancies, what birth control options are safety or best for MPN patients? This is one question. She says that she has PB and recently got the Mirena IUD after being told for years previously that I couldn't use hormonal birth control. So let's say that the question is, yes, which are these control options safety?
Maybe if I start, I just simply say hormonal, we don't like that much, the contraceptive pill, because, you know, the risk of increased thrombosis. But all the other measures, intrauterine device, I don't know, you know, all the stuff that also men could do are quite fine.
Usually yeah, Natalia, please.
No, I was just going to say, I think that is probably the rule that we all use is the risk of thrombotic events with oral anticonceptive medications in general with women. So that's well known. So obviously with our patients, we just have to be really careful. And
yeah, and generally we don't like estrogen treatments. So hormonal anticonceptive methods are not the best solution, and that's it. Yeah.
Okay. Emily, I think I didn't ask you what is your opinion about being pregnant.
I mean, I'm sure like most people, I read Dr. Google when I was first diagnosed and really freaked out. I was like, oh, so adoption it is or whatever. But hearing all this now, it definitely makes me feel so much better and that it is possible and can have a healthy baby.
Great. So we will have a baby boom. Everybody's happy to get babies. Good. I had still one general point, part of it we just touched about it, which is the question about, or the connection about menstruation, contraceptive pills, and hormone support. I said part of it we have just now touched, but about menstruation and here again, I cannot comment very much out of experience. But could you give your opinion? I mean, for MPN patients, is there any difference? I mean, I always thought, when you make blood analysis, when you have menstruation, probably the blood accounts are different, but this is just my idea. I don't know if there is a direct influence which you can have. Is the illness changing anything during menstruation? Do you have to be careful of that? Or please, why don't you help me?
Doctors or patients?
On patients. On women, yeah?
Yeah, go ahead, Haifa. Yeah.
Yeah. Okay.
Yeah.
No, I didn't know to whom the question was.
No, we
yes,
just
very simply. Menstruation, during menstruation, we don't have to do something special. But first, we know that iron deficiency is a big, big problem. And because of the blood loss, and iron deficiency makes symptoms similar to MPN, fatigue, loss of concentration, and all that stuff. And then with this iron deficiency, sometimes there is the so-called reactive thrombocytosis. Speaking, the platelet counts go high. And this is a very common problem in many, many young females. And how can you correct this? In a PV, we just don't simply give iron, We are very careful. But first of all, for example, we have to discuss, is the MPN well controlled? Because, for example, if you have very high platelets, ET, you have this so-called acquired von Willebrand, and you get bleeding. So maybe in that case, interferon would be a reasonable option to reduce the platelet count, and then the problem of the menstruation is gone, and so on. So really, there are several issues, or aspirin sometimes is the problem, increasing the risk of bleeding. So if the indication for aspirin is not that strong, just simply stopping aspirin could make the problem okay. So you have to look at that. And this is really a very, very common problem in young females.
And maybe just one more comment, that many women menstruate, they've got iron deficiency, and GP doctors, internal medicine doctors, they put iron supplementation. And I also always recommend to my MPN patients that I should control it, okay? Because if they take iron, especially in PV, for example, they can have higher levels of hemoglobin because of supplementation of iron. And we don't like it very much. So this is what we have to be very aware of this topic too.
No,
Okay.
not much to add for me, to be honest.
Sí,
It's a bit my mind stay away. You go ahead, Aura.
sí, yo sí que quería preguntar, mi hija todavía no ha tenido la menstruación, no tiene 11 años y todavía no la ha tenido, no ha tenido su primera menstruación, pero sí que toma Rivaroxaban. Y entonces no sé cómo es la menstruación de mujeres que toman Rivaroxaban, que toman anticoagulantes. Si hay que tener algún cuidado especial, si siempre son menstruaciones muy abundantes o no, o cómo es. Si hay algo que que tenga que decir cuando llegue ese momento que va a llegar en breve, si hay algo que tenga que decirle a la hematóloga o no.
I guess they may be a little more heavy, just because we know the same with any, so Rivaroxaban, Apixaban, any of them could be a little more heavy. So I will discuss that with the hematology team and the pediatrics or anticoagulation team. But I think, yeah, I'm just kind of thinking some of the women I have with Rivaroxaban, they have not really mentioned much issues. But obviously, I mean, we all know that the beginning of and when you start with your periods, it also could be a little erratic, right, until it gets more stable. So I think it's important that everyone knows and is aware of. Yeah. But I don't know if Prof. It's quite a young patient, so it's, yeah. I'm thinking on top.
Yeah, but yeah, we do have these young ladies with the thrombotic events having anticoagulation, the so-called NOACs or DOACs, the one you mentioned. And sure, as you said, it might be increased, but in many, we don't have abnormal things. So yeah, one has to wait and see and adjust accordingly.
Okay. I still have some questions which came in from patients which were sent us before. First of all, the risk of stroke, or let's say the risk of cardio problems in young PV patients, is it high? What kind of preventing risk of stroke with young, when you're getting older? I mean, when I got, for example, when I got diagnosed with PV, nobody was talking about heart problems. Today, it's continuously mentioned, but we have to watch our heart and we have to be careful, and we should go to cardiologist to check it. Can you tell me a little bit more about this general question of a heart problem in connection to MPN patients?
I mean, usually younger patients, they've got more venous thrombotic events. Then with the age, they will get more arterial thrombotic events. This is what we said previously. I mean, healthy lifestyle, good diet, doing sports, is no smoking. This is very important to advise, because why older patients with MPN, they've got arterial events? Because they've got atherothrombosis, and these risk factors increase the problems in arterial. So we have to prevent them. And yeah, aspirin can also decrease the risk of arterial events. And this is why we use frequently aspirin in MPN patients. And that's it.
Okay. Anybody else want to have some comments there? No. I've one general question. When I listen to the patients, especially young patients, there is a trend that the physicians they start at very early to talk to patients about transplantation, and this was, I mean, the whole question of transplant. It's coming up much more in the forums, in our meetings. People would like to know. We have, for example, we have a WhatsApp group which is only for transplanted patients, and it's just amazing how many patients are coming and are looking for information about to make a transplant. And especially young people were very often were being faced by the physician by the question. One came to me and said, well, my doctor says I should make a transplantation as soon as possible, because all the medicines which we have nowadays, they are not really doing, they're improving certain symptoms, but they are not very much active on curing. So I have some arguments against that, but I simply can see that there is a trend that the transplant question is coming to very young patients. Now, to transplant has a risk, and how do you see that? I mean, is that something which is just a trend, or is it something positive? But young people is confronted with a question to get transplanted.
I don't know, maybe I start. First of all, transplant is nothing for ET or PV. So I put that away. It is, we talk about transplant only if patients with ET or PV go into the myelofibrosis, or the young patients with myelofibrosis. We have to be very careful. The talk about transplant generally, everybody speaks about transplant doctors. But if you look at how many patients, only myelofibrosis, again, I think this is important. Most of the young patients are ET or PV, where transplant really, it doesn't play a role. But even in myelofibrosis, also in Germany, a country with a lot of transplantation and good units, we transplant only 5% of our MPN patients. So the talk is much more about transplant rather than the real number of actually transplanted patients. I could speak for hours, but I would like to have Marta's and the other doctor's opinion.
I mean, there are no clear recommendations for doing transplant in young patients, because the risk scores that we've got to decide if we should do transplant or not, they are mainly for older patients, not for younger ones. They are not working properly in younger patients. And there is still a topic to investigate, because we really don't know how to do the follow-up of younger patients, especially with pre-PMF or myelofibrosis. Should we do sequenced next general sequencing studies to see if there are any additional mutations coming. Should we control the number of blasts in peripheral blood? We still don't know how to do it. The only thing that we know, for example, when I've got maybe not so young patients, but when I start treatment with JAK inhibitors, I speak with them that if I decide to start ruxolitinib or any other JAK2 inhibitors, is because this patient is a candidate to transplant, and he need to be or she need to be prepared that in 3-4 months we are going to plan the transplant. And this is because we don't know how long the treatment is going to be working. And but in very young patients, if there are no signs of progression of the disease, there are really no clear indications to do transplant, and not for ET, for essential thrombocythemia, not for Polycythemia Vera, of course. We are not speaking about transplant in this group of patients.
Yeah, I mean, we probably have the same approach as it's been said. First of all, because the scoring system is for over 65. So, but I was also thinking, and consider the new therapies that we've been talking about it, that probably will change in the long term the approach for the transplant. So with obviously on these specific therapies, but also the therapies that are at the moment under investigation, it may change on the future. Yeah, we will not approach. I mean, you can talk, but in general, my approach will not be transplanting the first conversation. It will be more, okay, well, this is the treatment options if we even have to start any treatment. But yeah.
Maybe I just can add, for me personally, I don't do anything else in medicine apart from MPN. I don't see any other patients. So I see a lot of MPN patients, and I always say the most difficult decision for me is always in younger patients with myelofibrosis. What is the right time? Too early is bad. Too late is also bad. This is really the most difficult decision I make together. And generally, when I have these young patients, I always do a donor search. We search for a donor so that in case, and you know, MPN is not an acute disease. It goes over time. And I see a lot of patients for just second opinion, but I always see the younger patients from time to time, because then the follow-up shows you, are things going right or are they not going right? This is the way I approach this. Because as I said, it is the €1 million question for me, not to send patients too early or too late. And on the bottom line, I repeat myself, it's not more than 5% of the myelofibrosis that really get the transplant.
I think that is the key, isn't it? It's the difficulty is the when is the right time to do it. But yeah, I agree, it's a tricky one.
Can a patient help you in something?
Can a patient, sorry, Peter?
Can a patient help you something, to make that decision?
Well, I think it's two things. It's also the indication, and for instance, in the UK, if you have a low risk myelofibrosis, you're not eligible for transplant. So that is the other thing. So the patients that will go for transplant are those high risk patients, or intermediate too. So they are on the top up for the risk stratification. So usually, if you're thinking they will be like quite anemic, they will have blast, they will have abnormalities. So for us in that aspect, are they in that point to say, okay, well, it's not easy to take that decision, but you probably are moving through the transplant. But even that with the high patients, when I have the conversation with the transplant colleagues, because I don't do transplant, and we send them to the transplant services, it's always that big question. And as Prof mentioned, what they do is probably they start taking all the search for the donors, start doing all the baseline investigation for those patients. And they may go and see the transplant team, and the transplant team come and say, well, we can wait 6 months, because you also have to think in, and I guess that's the transplant is not coming to the hospital, taking the new cells, going home. Is having an intensive treatment, have been in the hospital for at least 6 weeks, 8 weeks, not having any complication during that period, with basically your bone marrow has been, clean for everything, and give you the new one, then recover from that period after. So we're talking about easy 1 year until you're back full. So if you think in 1 year in patients who are full worker with a family, it's a lot of other implications in the background, not only just the disease and how risky is the disease, so, is logistically impacting social life, impacting mental, just a lot of other things that the transplant, beyond medical problems that can have. So that's why the decision is that difficult, I guess, for doctors. Because if we're talking about an acute leukemia, which is a totally different setting, we have to treat that. It's acute. We treat it. We know the plan. Chemo, go for transplant. That's the plan. But a patient with myelofibrosis, you can wait in some cases, and as Prof said, you can do all the investigations, but it's not that needs sometimes to treat that urgently, I guess. But that's what probably makes it more difficult for us, because if you know you have to treat, then you do. And it's a lot of things beyond the transplant, just not only receiving the cells. Sorry, Marta.
No. I fully agree, because I'm also attending acute myeloid leukemia patients. So this is totally different disease. We've got really clear decision. We have to go for transplant. And then I was working at transplantation unit. So I had a lot of patients with myelofibrosis after transplants with lots of complications. So we know that this is the only cure for myelofibrosis, but it's also really heavy procedure, and we have to tell it to our patients, because I've got one patient that she wanted to be treated by herself, I would say like this. She did.
Hello?
Next general sequencing every 2 years. I don't know why, but this was her decision. Evolution, because she read this online. Can you hear me? Yeah, we have to wait. Molecular panel, but it's still monoclonal evolution. You don't have the disease. And sorry?
Yeah, you're cut off sometime, your voice, at least for me.
Yeah.
Yeah. Okay, anyway. Yeah. I think the question of transplant is clear, more clear, up to the point it can be clear. I would like to put a last question. I mean, it's getting late, but a last question. It's the combination of different treatments in MPN. We do have, every time more and more treatments, but sometimes, one treatment is affecting, say, or is improving 60% of the symptoms, and another treatment is affecting the other 40%. So what is your philosophy? Are you making these combinations that you give a little bit of one and a little bit of the other treatment, or do we have to wait until we have combination products which are at the moment under clinical trials, so that we can get these, combinations? Are you giving two treatments to your patients, two different treatments? for example, you combine Ruxo with interferon, for example?
Marta said it.
Yes.
They do this.
Yes.
I am very strict. I do the clinical trials for combinations because I always ask myself, what do I want and what are the goals of treatment? And I do combinations in clinical trials. I have some very small exceptions. For example, very high white blood cell count with many symptoms, where as an exception, I might combine Rux with hydroxyurea or interferon with hydroxyurea, but this is the exception. I do it all in clinical trials. And Marta said it previously that you do the combination, right? And you wanted the project, and I wrote to you.
Yeah, I know. I do the combination, but it's also an exceptional case.
The Austrian doctors, they very often combine Rux with the interferon because, I don't know, the insurance there has no problem with it.
Yeah, we do have some combinations, probably not that well approved in general, but we do have patients. I have patients with PEG and hydroxy, PEG and ruxolitinib. I mean, not the three of them, but they're different combinations. So we do. We even have sometimes patients with momelotinib and hydroxy at the beginning of the treatment. So we do have a quite mix on that. And I do think it's probably, I agree, we need trials on that because for some cases it looks that there is not enough with one medication, but it's defining that patient, what's the time of, presentation for the patient, is the high risk ones, is the ones with quite proliferative disease, the thrombotic. So that's what that we need the clinical trials for.
But I mean, basically, if you have a patient on interferon, which is not acting really on the spleen, and interferon works perfectly well, but the poor patient keeps on having a very high or expanded spleen, is it really no solution? But you can give him a little bit of Ruxo, which brings down the spleen.
I mean, this is the idea that we can use interferon that reduce the amount of JAK2 mutation mainly, and then we can give Ruxo, another JAK inhibitor, to control symptoms and splenomegaly. But of course, it's not a solution for all patients. Usually we use monotherapy, but in case that we are not able to manage these patients, we try to put 2 drugs. But I also do agree that we need the clinical trials. This is the best solution for all of us.
Yeah. I think, yeah. Well, from a patient side of view, it's, if we have a possibility that we have a treatment which is reducing his spleen, very often they simply don't understand why they cannot, besides of interferon, that they get also the Ruxo.
Yes, because you don't know what you're doing. That is the point. If you don't have enough data, we do try, in every desperate individual cases, we do all the crazy things in the world. I think we all doctors do this every day. But, it is difficult if you just combine and you don't know what you're doing and what are you expecting. And that's why I am always looking for, evidence-based medicine rather than just forgetting about, insurance and approval. That's the point.
Yeah.
I hate doing.
This is the problem
not
that we
knowing
have
what
to
I'm
manage.
doing. That's the point.
I think in all countries. Yeah. But also the problem of insurance and what we can use according to insurance. Sometimes it's not the same what we know as a doctors. And in Poland, we've got this strict protocol that we have to have the reduction of splenomegaly, that we have to have reduction whatever. And then the patient is a patient. Yeah. And we can see, for example, that he's much better on the treatment, but I'm not able to continue the treatment because the social security says no. And I say, why? Yeah. And I think that in whole countries, you've got the same problem. Yeah.
Okay. Good. Well, I think that I have more questions here, but most of it we have been talking about it already. So let's just make a last round, you know, for the doctors and for the patients. If you have any questions left, please put them up now. Otherwise, I think we deserve it all to finalize this Saturday. Any questions left over which we should have talked? Or do the patients have anything left which we would like to know?
A mí sí que me gustaría hacer una pregunta. He leído algunos artículos sobre medicamentos que sirven para otras cosas, como la metformina para la diabetes o el Montelukast para el asma, que a veces se utilizan en pacientes MPN. Y por curiosidad me gustaría saber si sabéis algo sobre esto, sobre medicamentos que son pues muy conocidos y que están y que claramente son para otras cosas y se pueden utilizar también para MPNs. Y para qué sirven o cuándo se utilizan o cómo se utilizan?
Yes, thank you. I might give an example.
No,
I love
I'm
this
sorry.
statin, the lipid lowering for the fat lowering drugs, because, you know, we have to improve the risk factors for cardiac, heart, and stroke. And we know very well that these drugs, they also reduce inflammation. So I am very generous with these lipid lowering drugs, for example. All drugs, simple, cheap, but they could be very effective.
Marta, any idea? Any question or any comment on that?
Yeah, this is the inflammation that we start to stop with metformin or with atorvastatin. The problem is that we don't know how to manage these drugs in very young population. So once again, we need guidelines for children and young adults. Yeah, because usually older patients then use these drugs usually because they've got hyperlipidemia or they've got hypertension or whatever. Yeah, but in very young children or in young adults, it's not so easy. But and we can control much better inflammation. So this is what we want.
Natalia, anything additional?
No, I disagree. I mean, it's what we were talking about, the trial with methotrexate. We know it's a drug using in a different conditions, and we are doing studies. But I think we need to have more trials and more investigation on that. And as Marta said, some of these drugs like are a more old population had already, so it helps another aspect. So I guess at the end of the day, we'll control the cardiovascular risk factors and prevent clots, and that's good. But we don't have much information yet.
Good. Well, thank you very much. I think it's a long time now. It's 3.5 hours. I think we touched on many points. I just wanted to thank you specifically to the doctors who spent their Saturday afternoon to be with us and to give hope, help, and future for the young patients. I think we learned a lot, and I hope that we will be able to repeat and bring up maybe new ways of discussion between the young people and physicians. Thank you very much that you have been here. It's a great pleasure, and I wish you a nice rest of the weekend, and we will be in touch. Yeah, thank you very much.
Thank you, and all the best. Bye-bye.
Thank you.
Thank you very much.
Thank you very much.
Bye.
Thank you.
Have a good evening or good day. Bye.
Bye-bye.
Bye.